So I want to welcome everybody to this SAFE event, San Antonio Interventional Forum. It's really remarkable what we've been able to pull together here, and I'm very proud of all the folks that helped organize the evening. Particularly want to thank Abiomed for their support for this event. I think SAFE has come a real long way, and it's really because of the folks in this room that we've been able to accomplish so much. And also, want to start by thanking the people who are going to present today. When they asked me what topic we should pick, complications are very difficult to show and to talk about, particularly in a public forum. So for our presenters in this evening, I want to thank you for taking the courage to present and show your work. And, complications we all learn a lot from, one way or the other. So it's an extreme privilege to introduce our guest speaker for tonight, Dr. Paul Tierstein, who's the Chief of Cardiology, Director of Interventional Cardiology at Scripps. He's really been a godfather of interventional cardiology for many decades and been at the forefront of teaching. I remember attending his course numerous times in La Jolla and learning so much. I first met Paul when I was an interventional fellow at UC San Diego, and we would meet in a forum not dissimilar to SAFE. It was a citywide forum. San Diego, like many cities, was known for a lot of personalities and conflicts and politics, but we came together in a citywide conference. It was held quarterly. I worked with one of the local reps there and the different folks to help coordinate things. And for 3 hours, we would sit down, go over cases. It didn't matter whether you were from Scripps or Sharp or UCSD or where. We would talk about cases, learn from each other, and we became friends that way. And that's really when I moved here 10 years ago, that was something lacking, and something that I know, Dr. Malik and Dr. Christofferson and I really talked about is increasing our collaboration, collegiality, and you've seen that with SAFE. My other memory of Paul is when I was a junior faculty member. It was my first few months out of training. I was faculty at UC San Diego. My partners were out of town. I had a very sick patient with aortic stenosis. And I needed help. I needed to balloon that valve. He was sick. I wanted another pair of hands to help me. So we got Paul emergency privileges, and he came over. This was over at Thornton at that time. And I said, okay, well, I presented the case, and we were going to do a balloon valvuloplasty. Paul had been doing TAVRs and a lot of aortic work at that time. And then Paul's like, well, I got to go fly my model airplanes. So I'm going to go fly my airplanes. Call me when the patient's loaded on the table. So the patient got loaded. We did the case. He did well. And I think Paul has evolved from model airplanes to flying his own planes now. He actually flew from San Diego in his own jet, piloted his own jet here tonight. And I think he's going to fly tonight to another location afterwards. So that's pretty impressive. So with all of that, I welcome Paul Tierstein to give our talk tonight. Thank you.
Hey, thanks so much. That's, wow, it's like the lights are on me. You brought back a memory of that. That was about, 15 years ago? Something like that. And I remember a couple things. I got a parking ticket, because I didn't have a sticker for my car. So when I got out to my car, I got a ticket. I also remember having trouble crossing. This is really weird. I had trouble crossing the valve. I couldn't get the wire through the valve. We tried the AL. We tried Judkins Wright, multi-purpose. And finally, desperation, I just used a pigtail.
How do you remember that? I remember that because, that was, something important for me in my training, my life. How do you remember that?
I remember that because it was important for me too, because I still bring it up because, TAVR, we're doing so many TAVRs, and sometimes you have trouble crossing, particularly if you're on camera or other people are watching. It's kind of embarrassing. And I always say, okay, we usually start with AL1, and then we go to JR. Multi-purpose can be good, particularly if it's a prosthetic valve. But I'm always saying, once I had to use a PIG, I always say it. I haven't had to use it since. I think DeMario came down, actually. He did, and he saw me struggling, and I couldn't never cross the. He finally got so bored, he left. I also just want to say this is a really great idea. You're absolutely right. We tried this in San Diego. We had some politics in the city, the usual, and that has gone away completely since we started this. When we do it every quarter, we get somebody to sponsor it. Actually, we've been getting, Medtronic has been great at sponsoring it. I will say, though, that Abiomed has really stepped up to the plate. As stent prices fall, it gets harder and harder for companies to sponsor this kind of thing. And Abiomed is really good at keeping complex PCI going. And it's been terrific because we've been doing it, I think, for 7 years in San Diego, and we're all buddies now. Everybody knows each other, and we enjoy the evening, and everyone has a great time. All right, so I was asked to give a short talk, and then we'll get into the complications. So I thought I would talk about PCI versus CABG for unprotected left main and give you my take on it. It's really short, because I know it's more fun to kind of have interaction, but this is sort of will kind of get us going. And then you wanted me to give a complication too, right? So I have a complication. I've got plenty of those. So let's do this. There's my whatever. I don't have that many financial interest conflicts these days. So how do you define a high-risk patient? This is what I used to show. Okay, that's sort of funny. Now it's changed. Now, lately it's been this, like no vaccination. That's a high-risk patient. So I don't know how many surgeons there are here. How many we have? Any? Okay, so, all right, so I'm going to apologize in advance, and you're welcome to give me a lot of pushback. I'm going to say some things that you're not going to like, but maybe you will, I don't know. But if your toilet was stuffed up and, you called the Roto-Rooter guy and he came in and he said, well, yeah, you got a blockage right there. I'm going to have to cut a hole in your floor and bypass it. You would say, no, my toilet doesn't need bypass. It needs an angioplasty or a stent. So what do I like about bypass surgery? Both internal mammaries. That's, those always, or not always, but usually look really good. What do I dislike? They're obviously the morbidity. Saphenous vein grafts. Can we stop saphenous vein grafts? I mean, this is one of my big beefs. They're still used most of the time. And saphenous vein grafts cause an acceleration of the underlying native coronary disease. And it's still the most frequent way it's done. I kind of was tipped off to this when an interventional cardiologist, who I stented a few times, decided to get bypass at Sharp. And the surgeon was Walt. You know Walt. Did all arterial grafts. I thought, oh, well, if you're a potential referring doctor, that's what you get. And that's really what you should get. And it's a lot more time. And I know about the ARCH trial, but it's, from our point of view, if a patient has arterial grafts, it's going to be a lot easier than the vein grafts that are closed. Because the vein grafts supply so much blood that they steal the blood, they steal the flow. The underlying disease gets worse. This was pointed out by Toby Cosgrove at Cleveland Clinic, like in 1981. Progression of atherosclerosis in native vessels was accelerated by vein grafts, and it occurred in over half the patients. This was an old paper. A more recent paper, 35% of native arteries bypassed with a vein graft progressed to total occlusion. And that's how it is. If it's a graft case on the board, right, everyone goes, oh, it's going to be a longer case. Because the grafts are going to be, a couple of them are going to be closed, and the native vessels, that's usually the internal mammary to the LAD's open, the vein graft to the circus closed, it's all calcified, we got a rotoblade, shock wave, it's often a total occlusion. So I don't know if you know about this trial. In the bypass world, there are very few trials where there is a systematic follow-up, angiographic follow-up. The PREVENT 4 trial was one of the more recent ones. It was about 10 years ago. And this was looking at a medicine to improve bypass graft patency. And the key about this trial is that there was 81% of the patients underwent 12-month angiography. And what they found is that by 12 months, a quarter of the vein grafts were occluded by 1 year. And 40% of patients had at least one occluded vein graft at 1 year. All right, so so vein graft and vein graft failure increased death in MI and revascularization. So saphenous vein graft failure plus native vessel disease acceleration, that makes a difficult day for us in the interventional cath lab. So now we have these risk factors for acceleration of coronary disease like smoking, hypertension, LDL cholesterol, obesity, sedentary lifestyle. Now we have to add bypass surgery, all right, with saphenous vein grafts. So I'm not a big fan of vein grafts. A big fan of bilateral internal mammaries, radial, but not bypass. So let's look at Excel, and I'm not going to delude you with data, but I want to give you a perspective about how I've been looking at data these days. So this was a great trial that Greg Stone did, 2,000 patients randomized with 91% follow-up with left main. It was supposed to be only syntax low and intermediate patients, but when the core lab looked at it, they found that 25% of the patients actually had a syntax score above 33, so in the high range. So these were not easy cases. Distal left main bifurcation in 80%. So I want to point out that ultrasound guidance was used in 77%. And this is, hopefully catching on here in San Antonio as it is in San Diego. We're using ultrasound now almost all the time, at least I am. Bilateral internal mammaries were used in 24% of the cases. So it was pretty good surgery, largely because there was a lot of European centers. Because in the United States, bilateral internal mammaries are used less than 5% of the time. So this was a bit unusual, and it was good surgery. Only arterial conduits in 24%. That's very, very high percentage for all arterial conduits. So the primary endpoint was the same at 3 years. And at 5 years, it was statistically the same, although there was a trend favoring bypass surgery. And this sparked this big controversy starting on the internet, okay? It's all these folks on the internet, on Twitter, getting upset with the way the data was interpreted because they thought the data should be interpreted as bypass surgery winning at 5 years. And it finally made its way to New England Journal of Medicine, where David Taggart, who's a surgeon from Europe, from London, who's a really good guy and a really good researcher, he at least came forward with his criticisms. And they were, it's hard to read here, but he says, first, the incidence of death from any cause was 13% in the PCI group and only 9% in the CABG groups. So that's a 38% decrease in death if you had bypass surgery, and he thought that was important. And second, the investigators kept saying that there's no difference in cardiac death, but it's very difficult to attribute the cause of death in these studies. Those were his two major criticisms. So let's look at this. When you look at it, you find out that, yeah, he's right. Death all cause, 13% in PCI versus 9.9% for bypass surgery. And cardiovascular really wasn't that much different, but let's just say David's right and take away the cardiovascular and just look at all-cause death. PCI was associated with a relative 38% increase in death. That sounds pretty bad, right? But that's not the way I describe it to patients. And I don't think that's the way patients really would interpret it if they, it's kind of what we learned these days is you can interpret data in many ways. So I just flip that around and say, okay, what about freedom from death? What are my chances for being alive? Well, with PCI, at 5 years, it's 87% for left main PCI. With surgery, you could jump that all the way up to 90%, but you have to have a thoracotomy. All right, so is that worth it? It doesn't look so important anymore, does it? I mean, that's the problem. And the difference, the absolute number is 3.1%. So another way to look at this is to divide that number into 100, and that gives you the number needed to treat. So you have to do 32 open chest procedures to save one life compared to doing a stent procedure. And that makes bypass surgery a little bit harder to swallow from a patient's perspective, I think. You can take this to repeat revascularization. Any data point, you should look at it in this way, I think. Repeat revascularization was worse with PCI, 17% at 5 years compared to 10%. That's a 57% increase in subsequent revascularization. That's not so good, right? But just turn it around. What is your freedom from revascularization? What are the chances of not needing another procedure? Well, if you get stents, it's 82% at 5 years. That's pretty good for stents. If you get bypass, it's 89%. Kind of not that big a difference in my opinion. The difference there is 6.7%, so the number needed to treat is 15. You got to do 15 open chest surgeries to prevent one, PCI, which is, radial PCI. It just doesn't seem worth it to me. What about stroke? Stroke, cerebrovascular events was 3.3% in PCI, and it was 5.2% in the surgery. Should I say that CABG is associated with a 58% increase in stroke and TIA? I don't think so, because that would give the patient the wrong impression. Because the stroke rates are pretty low, serious stroke rates are pretty low in both groups. And they are slightly higher with surgery, but they're still pretty low. And this, if you remember, the FDA commissioner a few years ago got in trouble with this because there was a relative reduction of 35%, and he thought it was 35 out of 100 patients who got plasma, who got antibody-rich plasma were saved from COVID, and he kind of made a really bad mistake. And the point here is don't worship p-values. If the study is large enough, a tiny difference will have a significant p-value, and that's the key, I think, to try to help your patients through these tough decisions. So who do I send with unprotected left main for bypass? High syntax scores with unprotected left main, they always have a 3-vessel disease in that situation. Intermediate score, I used to send them to surgery, but syntax, the Excel trial really turned me away from that. So those patients, I usually do PCI, and if they want. Insulin-dependent diabetes. If it's a non-insulin-dependent diabetic, actually in Excel there was really no difference. But insulin-dependent diabetes, I think that's a different animal, and those I'm tending to send to bypass surgery. Of course, the DAPT intolerant patient, total occlusions that you can't get open, several restenoses, and that's a very typical thing for me. A patient's got now double stented the left main, they still don't want to go through surgery, but I say to them, look, I think it's time for you to get a bypass at this point. And if they're really a good, easy bypass candidate with good targets, and they're a lousy PCI candidate with proximal tortuosity and calcium, those cases often I send to surgery as well. And I break the above rules when they're a bad bypass candidate, so frailty, oxygen dependent, no targets, and then there's patient preference, which is becoming more and more important, especially when the syntax score is borderline. Now we have the new guidelines, right? The new guidelines are just released. They're very controversial, and I can see why. But I would recommend that you actually read them. They're not that hard to read. It's like 70 pages. So if you print it out, if you look at it on your computer, it seems daunting. But I told my fellows just the other day, I said, if you read these guidelines, that's probably all you need for the boards. I mean, they do a very good job of going over the entire field. And left main now has a 2A guideline recommendation, which is pretty positive. They also we're talking about hemodynamic support a little bit because Abiomed is supporting this, and it's a relevant question with left main. That got a 2B recommendation. So if you're comfortable with it, you should do it. In fact, my feeling about it is Impella is now in the guidelines for complex coronary disease. You don't even have to have bad LV function, but you find your own comfort level of what if you feel like you want to put Impella in to do an LAD diagonal bifurcation, just do it, okay? I mean, I don't think you need to do it, but I think until you get comfortable doing that, if that's what you need to do, then I would rather you do that than send a patient with an LAD lesion for bypass surgery. When I'm doing an unprotected left main, I think about the right coronary. Is it occluded? Am I going to be working on the only remaining circulation? And is it a bifurcation? Is it calcified? Then I'm going to think about Impella. What's the LV function like? Is it 35% or is it 20%? Femoral access issues. Is there a nice big juicy femoral artery that I'm not going to get in trouble with? Then that sways me more towards putting the Impella in. And I strongly think about the complexity of the anatomy. It's the unprotected left main that's really calcified, that's tortuous, where I worry about, am I going to shut something down when I'm trying to wire it, just because the circumflex goes back on itself. Something like that, I will think about Impella pretty strongly. And I don't usually ask for anesthesia, but I left this in here because we're using anesthesia more and more lately in the cath lab. In fact, I strongly believe that we should have 1 or 2 anesthesiologists in the lab every day. Because this idea of calling for anesthesia when the patient's trying to get off the table, or when you get in trouble with a case that you didn't predict you'd get in trouble with, and there's no anesthesiologist around because they're not just sitting around. I don't think that's a bad thing. I think patient safety dictates that we should have anesthesia around, which means they should be in one of the rooms doing conscious sedation with a nurse, and they'll be able to leave to do a emergency situation that might arise in the cath lab. Oh, I should say something about IVUS and unprotected left main. You should be doing IVUS if you're doing unprotected left main. This study showed that stent under expansion in the left main was a bad thing. It's really easy to do. I really highly recommend it. This study divided the left main into 4 different territories: the ostium of the LAD circumflex and the proximal left main, and also this polygon of confluence. And they come up with these numbers you should target for when you do IVUS for your minimal luminal area. 5 for the left circumflex and 6 for the LAD, 7 for the polygon of confluence, and 8 for the left main. So no one can ever remember them, okay? So all the fellows are coming to me, well, what was those numbers again? So I'm gonna give you a trick to remember them, okay? So you'll never forget them. Remember dance class? 5, 6, 7, 8. Okay, so now you won't forget. That's what you're looking for, 5, 6, 7, 8 as a final. All right, so what's missing finally from the CABG versus PCI debate? Why does it always focus on mortality and repeat revascularization? Shouldn't we include morbidity endpoints? Return to work, pain. This is a New York Times opinion piece, and it says, it's about 10 years ago, the writer writes, and when my surgeon, whom I adored, said he would have to stretch my sternum to get to the heart, I didn't realize it would be taking a saw to stretch it. So I'm just joking. This is in my ICU. I took this picture about 20 years ago or 15 years ago. It's a patient postoperative day after bypass. I can't show you her face, but you can see her right arm there reaching out for help. And then, of course, in the next room is someone who had a radial PCI going home. And then, this heart team idea. I know at the podium you're supposed to say the heart team is a great idea. I think the heart team is still very helpful for structural disease. For coronary disease, I'm one of the few people that's kind of negative on the heart team. I just think it's unfair to the patients. I'm not saying they shouldn't talk to a surgeon. That's fine. Give them the option to talk to a surgeon. But my father used to say, my father was a pulmonologist, and he would say, medicine is not a democracy. And I find that very few patients can really analyze the data and make an informed decision. Mostly they make decisions based on the confidence they get from the surgeon, and the confidence they get from the interventionalist. I mean, they really size you up when they talk to you. Also, the fear they have of open chest surgery and the experiences of their friends and family. So, the patients that I find will choose bypass are the ones that tell me, my dad had a bypass, he did great. And then if someone they know had a bypass and they didn't do well, they were in the hospital for 3 weeks, they don't want that. And the same things, the opposite is true with PCI. If they had the same thing is true. If they had a good experience with PCI, then they like it, and that's what they want, and they don't want bypass surgery. Now, the decision's controversial, and it's really important you tell them about the options, because if you have a bad outcome, you're going to get sued, most likely. Particularly if the patient has earning potential, you're going to end up with a suit. And the easiest thing will be for the attorney on the other side to find an expert who will say, what was Tierstein thinking? He should have sent this patient to bypass surgery, of course. So you need to make sure the patient and family know that there are alternatives. I say things like our heart team isn't in agreement on the best treatment modality for you, but if it were me or a family member, this is what I would recommend. I also use the phrase, I say, well, if I had 100 cardiologists in a room, I think for you, 70 of them would recommend bypass surgery. Depending on what I really think would happen if there was a room full of cardiologists. And I tell the patient, look, I'm willing to do this if you want, but I just want you to know that most cardiologists would recommend bypass surgery. I don't actually agree with them for you. And if I do agree with them, then I make a pretty strong point. I still have patients sometimes twist my arm. Now, what is informed consent? You don't have to put
Look at the sternum.
We don't need to have
down, please.
sound on this, but that's going to make it even worse. Should we show this kind of picture to your surgeon. Is this informed consent? Should we tell them about all the things that could happen? This is coming up to my favorite. This is my favorite part right here of the movie. All right. Oh boy. Now, if I showed this, my wife was in the my wife was in the airplane today. She said, "Oh my gosh." She saw that. Of course, that's not fair. On the one hand, on the other hand, that is what happens, right? And it's pretty crazy. So I'll finish with a thought experiment. All right. So Rene Favalaro. Now was not the first person to do bypass surgery, but he gets credited with it because he was the first one to actually do a series of patients and report them, not just one. And he did his first bypass in '67 at Cleveland Clinic, and then Andreas Grunzig was born about 15 years after him, and he did his first PCI 10 years later. All right, so let's imagine that it was reversed, and Andreas was born in 23 instead of Favalaro, and Favalaro was born later, and Grunzig did his first balloon angioplasty in '67. Then, 10 years later, Favalaro proposes a new novel idea. Instead of spot treating the coronary disease, the entire vessel could be bypassed. All we need is a thoracotomy. How would that go over, right? I don't think it would go over very well. So just something to think about. You know, the conservative treatment is really the one that was there, not necessarily better. So you can call me now, or you can call me later. Remember, bypass surgery is very hard to go through more than once. Your saphenous vein grafts will likely close down. Your native vessels will likely shrivel up. Your subsequent PCI will likely be more difficult. But PCI can be repeated as often as you want, and you can always have a bypass sometime in the future, or maybe never. Bypass to bypass. And finally, every fall we do this course. This is going to be our third course for 33 years now, and it's a lot of fun. We take the hardest cases we can find and do them live, have a lot of discussion, and we always have a lot of learning, and you're all invited this fall. Thank you for your attention. I have a complication, but anybody want to give me any pushback? Well, I mean, there's a patient that came to me, such a funny story, from Texas. He came to learn how to put stents in, Palm-Maj-Shat stents, right after they got approved. We had a training system going on at Scripps because, Richard Schatz is my partner. And so Marty had one on the East Coast and we had on the West Coast. Every 2 weeks, people would come out, docs would come out to take the course. Then they had to be proctored to put Palm-Maj-Shat stents in. And this guy comes out. I have to be careful not to say his name. He's become a good friend. And you all know him. He's from Texas. Not here, but not that far away. And about a week later, he calls me and says, I got to come back. I need a stent. And I said, so, what's going on? He said, well, I'm getting angina. He said, I'll never forget it. I was on the phone. I'm getting angina. He has a little accent. And I said, okay, have you had a stress test? I don't need a stress test. I need an angiogram. Okay, do you have a card? When do you want to come out? Well, there's a meeting in 2 months out in San Diego I want to go to. Do you have a cardiologist? I don't need a cardiologist. I'm a cardiologist. I said, well, would you tell a patient who's having angina like that to wait 2 months? He said, no, all right, I'll come out next week. Comes out, he's got a right coronary artery stenosis. And again, I never forget, I always keep my interventional cardiologist light on the table because I want them to look at the films. I don't want them to get off the table and look at them later and say, hey, how come you didn't do this one? Or, So, I'm working on him, and I shoot the right coronary, and I can see there's a lesion at the crux. And then I hear a voice, can you go a little more LAO? And it was him. And so I put a stent in. This guy came back to me for stents literally every 2 or 3 years for 20 years. He started when he was 50. And he would try to time it around this course. He would always come. He said, "I'm going to come to your course." It was always a struggle because I was pretty busy around the course, but I always fit him in. Great guy, and he always wanted to work. He wants to work. He's a very active guy. Now he's 70. This was about 3 years ago, and he now has 2 stents in his left main. I've put in like 13 stents. There was no PCSK9 inhibitors, et cetera, et cetera. But so I said to him by his first name, "I think it's time for surgery." I said, "I think, he said, he said, "That's okay. It's been 20 years, actually 22 years. If we had done surgery, 20 years ago, the grass would have closed, would be, so I think it's okay." So he gets bypass. And by the way, at Scripps, no vein grafts. Being Jeff Tyner, probably because he's heard me give this talk, he does all arterial grafts 85% of the time. And this guy got a great operation. I go up to see him the day after surgery. He says, Paul, this is horrible. I will never send a patient to bypass surgery ever again. This is like, I can't believe how horrible this is. 5 days later, he was on a plane back to Texas. I call him 30 days later. How you doing? I feel great. I'm back at work. I haven't felt this good in years. So that is kind of the story. You know, it's not easy to go through. For the right time, the right person, it's the right thing to do. I mean, it's a great invention, bypass surgery. But he really taught me a lot, that whole thing of, you know, and I tell my patients, you know, it's going to be a tough couple of first days, especially the third day when you're trying to move around, but it's going to get better. And by the time a month comes by, you'll be completely through it. So that's not a bad discussion. Should I show what's a complication? Yep. Okay, so people send me New Yorker cartoons all the time. The procedure is risk-free as long as there's no complications. Okay, so, all right, here's the case. 70-year-old male with angina. The circumflex is occluded after a medium-sized obtuse marginal. Patients had bypass surgery and bypass is closed. The lima is actually open. So, you know, I did this a few years ago. I ended up getting through the CTO with a Miracle Bro 6-wire. These days, it's really different now. Boy, that Mongo wire is amazing. Sometimes I might have to use a Gaia to get into it, but quickly switch out. And the antegrade technique, boy, I mean, I actually complain I'm not doing enough retrogrades because I usually get it antegrade these days because the technology is so good. So I get through, no big deal, switch out for a soft wire, everything's going well, pre-dilate the CTO, no problem. Everything looks, you know, it's going to be a long lesion, but this is good. Put in a long stent. It looks good, right? I got to do some more work distally. But I pinched this obtuse marginal, which was the one that was open. I don't like that, right? So I go back and I couldn't get a wire through it. So when I pull out the Miracle Bro is really good because it's got some push to it. It's a little stiff, and you can twirl it, and you can really maneuver it, and you can see it well, but it will go subintermalania, and be aware of that. It can do that. All right, so I'm trying to put this wire through, and it's not going through. And then I tried a few other wires, and I don't know which one this is, but you know, it's clearly subintimal there. It's just not in the right spot. All right, so I keep trying, continued attempts, but now it's getting worse. Now look at the appearance. Patient now starts complaining of angina. And then you hear ST segments, you know, on the monitor from the monitor nurse. That just makes you feel, you know, we all know what that feels like, right? Now you're guilty, right? Okay, you like taking care of patients who are having heart attacks. That's great, as long as you didn't cause the heart attack. So I'm thinking, am I going to shut down this only open marginal branch? And you know, the stress starts to build. What should I do? You know, I can't seem to get through. Any ideas? Often no one realizes. I'm showing this case for a reason. And often people don't realize what you should do. Most people don't realize it. Say again? Take out the wire?
There's a wire in the OM.
I can't hear you.
I'm sorry, there's a wire in the OM right now.
What should I do with it?
Take it out.
Take out the other wire.
Yeah.
Okay, any other ideas? So this is great because I forget this. And this is one of the reasons I like to show this. That wire, like why do we put a safety wire down when we're doing a bifurcation? What's the reason for it? To show us that to keep it open? To splint open the vessel? To use it as a target? Okay, that's what we always think, it's a target. But actually, you can use this big time, okay? All I did was take so now this is where I'm supposed to ask you what I should do. Look at that vessel, I'm really a mess here, right? I took a 1-tube balloon, passed it under the stent, right? You can't see it here because when it inflates, you can't see a 1.0 or a 1.2 balloon. But even a 1.5, I'll pass under the stent. So I'm using the wire that's been trapped. Then a 1.5 balloon, then a 2.0 balloon. All that's real quick. Now look what's happening. Now I got flow. I can breathe, all right? I can relax. The patient's happy. All right, I'm not going to go home to my wife and say, ugh, that was a terrible day. And I can think. And what I did then, and you could still, at this point, you could try to get in again, but I didn't. I did the reverse crush. So then I took the stent that was, the wires behind the stent, and I'm just going to fold the stent over. All right, so that's what I did. I took the other wire out. That's been stented, and I stented the stent over. Things are looking really good now. Okay, the distal vessel looks crummy. It's going to need some more work, but then I did proximal optimization. I don't even remember what POT stands for, but we call it POP, of the proximal circ. And then I put, so now everything's, I gave it a little nitro, everything's perked up. I got to put another stent downstream, of course, and I can't get the wire down. I just can't get the wire down. Any other ideas now? This wire will not go there. Any ideas? I did IVUS. I put an IVUS catheter in the obtuse marginal. Listen, when I'm having trouble or if something looks funny on the angiogram, I love IVUS now. Once you start doing it all the time, it takes, I've counted, it's 120 seconds from the time I say, let's do IVUS till when I have an image, just because the lab's used to doing it. And so here's what I see. As I pull back, look at that proximal. I didn't do very good optimization. Its stent is just floating there. It needs better pot. I mean, that's the problem. And I didn't have any clue of this from the angiogram. So I used a much bigger balloon, and then the wire went right through. Zero problems. And stented it. Final kissing inflations of the bifurcation. Put a stent in, the distal. Did some final IVUS on that, and now you can see the stent is very well expanded at the proximal segment. And that's the final result. That's a great result. That's a great result. So that's my complication. Thank you for your attention with that. Any questions, comments? Thanks. So we're going to show some complications now. Okay.
All right, Paul, thank you so much. We're going to introduce our panel and get everybody lined up here.
Hi, Paul.
How you doing? I see we talk about the
Yeah, no, it's really different, isn't it? It's really different, yeah.
lights.
All right, so it's my pleasure to invite our panel up here. They're all cozy and right
It's
next
the
to each
light
other.
series. He's telling me the lights are really bright. You know, it's why I don't like the main arena. Speaking at the main arena at TCT is very weird, right? Because you're just not used to being on the spotlight. We're not
exactly.
performers. It's really bright. Yeah, it's okay.
All right, so I'm going to introduce our panel here. So we have Dr. Mang Shah, who's the Chief of Cardiology at St. Luke's Hospital. We have Dr. Ahmed Al-Mamani. He's the Director of Structural Heart Disease at University Health System and UT Health. And we have Dan Donovan, who's the co-director of the heart valve team at Methodist. So thank you guys for joining us. We're going to start off with our first case. Dr. Donovan's going to present the case for us for our first complication.
Okay, good. Okay. Do I run it? There we go. Okay. Okay, case presentation as I work with the structural team at Methodist. Patient comes to the new patient clinic visit. She's a 79-year-old woman with severe stenosis, NYHA class 3 symptoms, mild non-obstructive coronary artery disease, history of ocular emboli, and she's frail. She's 79, 4'8", weighs maybe 190 or so, and but frail. Echo was done, I'll show it in a second. Normal LV function, very severe concentric left ventricular hypertrophy. Mean gradients at 44. There's some mild to moderate aortic regurgitation. She's got severe MAC, and she really has extensive calcification mitral valve up the LVOT to the aortic valve. And the calcification, as we can see on this, is fairly significant. I'm not sure if I can make this run. Oh, no. No, I won't do that one. You'll have to set me back up there. I won't touch those buttons. Oh, there's a bit. Okay, we'll back up a little bit. Keep on, perfect, that's what I got. Okay, I got the buttons now, sorry. So if we can just run that, is it possible to run that one? It doesn't matter. What you can see there is, good. You can see significant calcification of the valve, but what you really see is that LVOT calcification. The MAC is very significant, and the LVOT, I should have got a sitting CAT scan. You'll see CAT scans afterwards, but the mitral LVOT calcification was significant. And so when we presented at the valve clinic, we had to first decide what type of valve we want to do. We want a self-expanding valve or a balloon valve, and we elected, because of the calcification and the risk of annular rupture, et cetera, we elected to go with a self-expanding valve. And here it is. So I'll run this in 1 second, but so it was a bear getting across this. This is the one where we go, I should have tried the pigtail. I got it across, and I got the AL1 in, but it wouldn't sit. So I had to leave the straight wire in, go over wire, and then put a multi-purpose in, et cetera. I hadn't left a straight wire in whatever 700, 800 cases. I'd probably done it one time besides. Usually you can just leave that AL1 there, hang it, put your regular J-wire in and go on. But this was a really tight vessel. So based on that, we felt we definitely had to pre-dilate it. So we pre-dilated with a 20 millimeter by 4 centimeter nucleus, soft balloon, not that large. Average area was, we calculated 24.5 diameter. So if I can make this run. Oh, good. And so we blow it up. As you can see, it's tough, and then bam. And so...
I can't believe it. I had that same complication.
And so we pump this, and what you can see is that it still is not a very large balloon. I mean, it gave plenty of space, but there's a lot of calcification. At this point, we proceeded on. There was no real issue with this so far, and so we go to the next view. That's it. Let's take a look. Okay, and we can run that for me, please. So this is sitting fairly well. We went a little low. I knew I was going to have to re-balloon it, so I didn't want to lift it up any higher. You can see it's probably 3-4 millimeters below. Would we like to get a little higher with the Medtronic avoid pacemaker? Yes, but we put it down knowing I was going to have to balloon it again. At this point, it didn't look like there was any perforation. And what you can look up, you can see all the calcification. There's nothing there, because the risks of perforation on annular perforation is both aggressive pre-balloon and then post-balloon.
So Dan, looks like the patient was intubated, is that right?
He was intubated,
So
yes.
did you have a TE down?
I did, yes.
And no effusion?
No effusion, nothing. And so we proceeded on. Yes, that's it. Okay, so valve looked mildly constrained at this point. You knew what was going to be. And 2+ AR, and you knew that was going to happen with that type of... so we went in and decided to balloon it. This time we went with a 24 millimeter. We went with a soft balloon, a Z-Med. We didn't go with a true. We didn't try to blast it. You were supposed to go 1-to-1 or so, not anymore, but go a soft balloon, and we inflated the balloon. And if we can run that, please. If it's possible. But have I been running it, or do you guys run it? There you go. Good. Thank you. And so we balloon up. You can see it. You're going to see it expand. You can see some of the calcium move. And did we pick too large a balloon? I mean, it measured everything. It was less. It was more than 24 diameter average. And we finished the balloon. And everything looked good. The gradient was 0. There was trivial to no aortic regurgitation. And hemodynamically stable, like I said, AV gradient nothing, gave a little protamine, got the sheath out with a manta, hadn't got this over this hole, gloves off. I'm pretty happy. We got it done with this calcium. And the anesthesiologist kind of calls over, hey Dan, I think I see a pericardial effusion. And so next, damn. So pericardial effusion there. So thinking quickly, we got to think quickly now what's going on. Could I have perfed the wire? Because this is the first time I've left a straight wire in probably 5-6 years in there. But you can look at that LVH, and that's not a perf. There's no way you're going to perf that LVH. And so obviously, so the sheath was still in, so we did a angiogram.
The other thought is the pacing wire too. For the
And the pacing wire, yeah, and the pacing wire was, we went through that as well, because it had been put in from above. I didn't really see it go in, so what is the reasons? But I looked at...
You know, I want to take that LVH as a no for perforation. There was a case in my training where we thought this is like severe LVH and used as a safari wire, and that lacerated the LV in a couple of places. And retrospect, a lot of those patients, they have amyloid and they have other stuff. So,
Right.
you know, I mean, I just won't take it for granted that LVH is something that's not
Right,
there.
it's protecting you necessarily.
3 wire perforations with the Safari. Back in the old days when we were using core valve and you would push on the wire intentionally
Yeah.
to straighten up the valve, that's a bad idea.
Yeah, we did it when we were doing the Boston Scientifics in the trial, because it went deep and the wire wrapped, and we got a couple same type, and I couldn't figure out it had to be a wire perforation. I couldn't have thought that. But so I looked at it, thought pericardial, thought annular rupture, and so we took a look. Still relatively, and if we could play that. So I did ascending aortography, and this was within a minute or so. If we can
Hit
play
next.
that.
Yeah, maybe go next. And
Oh, there, okay. Oh, yeah,
think
maybe
you're-
I just have to do
you're
that. Okay,
controlling
good,
it,
yeah,
yeah.
I am, okay. And so what you can see is that there's a pericardial effusion, and right there's just a seep, and I'll go over for the crowd, but right, and it's really hard to see. In fact, I said, oh, it's a perf, and but nobody really even saw it, and then they
That's
started,
where
and I
you always
point out.
see it, too.
What's that?
Under the left main is where you always see it.
Exactly.
Yeah,
That's and that's exactly where it was, just hanging right under the left main. And so we decided, what do we do? To go in now, do surgery in this frail person. No, we decided to do a window real quick. Oh, actually, not even window, just kind of threw it was a window, but left a drain in. She stabilized remarkably quickly, which they can, you know, especially if it's kind of a contained perf. And then, and so then we sent over the CCU, and you know, annular rupture, got the volume presses, stabilized real good, got the pericardiocentesis, transferred the unit, and was remarkably stable in the unit. And at this point, I went off to Scripps Talk to watch you do a heavily calcified with a balloon, and my Dr. Alvarez, the other person that does a lot of what we'll be talking about, was away on a vacation. So fortunately, she kind of rode through for 5 to 6 days, and we came on back. And at that time, we did our first CAT scan. And what you can see in the CAT scan over here is that there's the perforation, if I can keep this. So we have a kind of bilobe perforation. Here's one right there, but it goes up here as well. It's not underneath the pericardium, it's just under pericardial fat right now. But the things you can see, and I'll talk about this in a sec, but you can see this right here, the part of the stent is inside the beginning of the perforation. And that perforation is 1 centimeter in size. And so it's not a little just micro perforation at this time. Might have started that way, but it's 1 centimeter in size. So now we have to decide what to do. We have,
what's the left main to plug? You know?
oh, and here's another picture of it I got on the CT. And so in the CT, you can see it right here as well. Here's and down there, it's right there. Right there's the perforation, but it folds out, so you can see this bilobe perforation, and you can see where it is. Here's the left main. It's wrapping the LAD in the diagonal, which is going to make a difference in my next choice as to how we're going to take care of this.
How many weeks later is it?
Wow.
This is 5 days later. And this is my third CAT scan. This is the one before we did a procedure. So on the third CAT scan, It had started to clot in the distal little air of it. It looked like a snowman is what we almost described, but it was still, and so we had 3, we could watch it. But it's hard to picture this 79-year-old frail woman with a 1 centimeter hole in the LVOT going for a long period of time. Don't know, I didn't see a lot. In the short term, these can potentially heal and stabilize, but in long term, pretty unpredictable. The second thing we could do is valve surgery. The problem with valve surgery is, 1, fail, 2, you're taking the valve out and replacing it, but it's not just repairing the root, you've got to somehow find the material to wrap the LVOT as well. It's going to be tough. Mortality, estimated at 75%, looking through the studies, mortality is going to be 50 to 70% anyways. Surgery is going to be at least that. The next one it actually is put in another valve, but we felt we were going to have to go too deep, put a skirt down across, it's a 1 millimeter. So the last option, we thought about plugging it. So I got back, tentatively planned for Tuesday, talked to the CT surgeon. He says, okay, just don't mess it up, Dan. If you're going to go plug it, don't mess it up. And I already got a 75% start, and you could make it a lot uglier. And so, but as I looked at it, I was real worried about plugging it. Now we plug, especially George, the partner, we plug a lot of stuff, aneurysms, et cetera, in the LV and the aorta, et cetera, and obviously VSDs, ASDs. But I was real worried about that spike, multiple things to worry about. That spike coming down, covering that hole. So when I'm going to have to get a catheter that I can actually turn and sit in the lesion, because you have to pull it out. When you pull it out, you're going to come at an angle, so do I cant the plug coming out, very unpredictable. And the other thing is, since it was 1 centimeter, I couldn't use a VSD plug. I actually had to use an ASD plug, which is 17 millimeters the smallest, and that was going to impinge on the left main LAD. And so if not now, future is going to be issues that we've seen before in PED stuff.
Any chance of putting another valve in?
We'll put another valve. We looked at putting another valve in because that's what it is. We talked about it, drop the skirt lower and try to cover the end of that. Go low into the LVOT. Don't know how much we would have, that didn't really come out. We threw that out because we said it, but we didn't think about it.
Well, an ASD or VSD device would probably be very difficult in that situation.
It would be. Just the angle. And so we actually thought about it even with Feldman. We thought about put a 6 French, a 7 French sheath percutaneously transapical or get a transapical approach, because you might be able to sneak it up under that. But I didn't want it. Frail woman, transapical. And so we went plug, but we decided we would think about plug, and I just felt uncomfortable about it. So I went down to sub-level 2. That's where we hide radiology. And 2 people down there, Dr. Lane, who's a phenomenal at CT, angiography, et cetera. He just saves us. He's a major part of our team. And a Dr. Zink, who does a lot of coil in the brain, and is, again, remarkable in South Texas as far as that. And could we coil it? And so I felt that was going to be the safest. I went back to the surgeon, who was in the middle of surgery at the time, and I says, I'm not going to plug it, I'm going to coil it. You're going to coil it? And so we went on down, and we coiled. Now, this is an angiogram where you can see what I did. I first tried to do this catheter, an Agilis, which you can come down and you can curve, because I was hoping I could just pull it up into it and help them out. But it's not long enough. Even she was 4'8", I says, I can get into Agilis, but I couldn't get it up there. I didn't think about going from above to do it at the time. So I got a Lima catheter and aimed it. And you can see right there it bulging out. This is all, there's the kind of the top of the snowman. And we got it. So what he did was, and I got access, he did everything else. And he liked being a distance. And he had never done it in the heart. It's a little different. It's like going to your mechanic, and the mechanic says, I did a valve job. Why do you get $10,000? I get it because my heart moves. And so try fixing the valve while it's moving. But he was doing it moving, so he puts his first one. It's a 40 by 15, and he keeps on going. He puts it in. Now he still has to get the top of the snowman, and he gets it. And the key is it's got to be black to stop all flow. And he got everything black. Next day, no effusion. Done, and she's been doing great.
How many coils?
9 coils. Started with a large one at 40, dropped it on down, a few 30s, dropped into 15, and finished it up, and it came out well.
Have you considered a vascular plug, like an AVP2? Because that can go through a multi-purpose telescope into this, go into this leak, and then just put a 14 French AVP2 through a 6 French guide.
Yeah, I was worried about the way that was spiking down there, and I didn't know what happened with my release. I don't know. I would want it to be able to sit and I agree. I think that
It gives you the flexibility of two catheters. Where
right,
you can
exactly.
Have
You
the
can
curve
come up.
and
Yeah.
look it up.
With the angle, that's
Yeah.
Yeah,
That was
but
my
then-
worry, kind of coming up and under what type of, we've been able to, there's a bunch of catheters, we've done a lot of aneurysms in the left ventricle, up in the base and so on, you can pull it up. But I was just worried where that valve was, how I'd be able to work my catheters, whether that would get in the way or not. But,
So after the initial valve deployment, what did the TE look like? Before the post-dilatation?
oh, fine, no pericardial effusion, nothing was there. My guess is that what happened was on the first balloon there was a small microperf. I would have been surprised if not. And then when we did that second one, it was like ratcheting up to make a 1 centimeter hole. That's a good size hole. And so I think it ratcheted up. And when we looked at the CAT scan, we could see the piece that could have just ratcheted the hole open. But there wasn't anything on that first one before.
That's a 9 coil. You're really lucky you had someone to do it with you who
Oh,
has
yes.
had a lot of coil experience.
Yeah, no,
Because that's serious coiling, 9 coils. I've never had that situation where I took that many coils where I have to make it that dark, and that's interesting. Usually it's an APV plug that we end up using, but I can see this is a very unusual place to work, and is doing harm could easily happen. Most of these patients die.
Yeah, they do,
You get a
exactly.
rupture, most of these patients die. That's a 1% risk of that with the Edwards valve, and it's pretty horrible. And we're better at that now because we kind of know to size it down, but quite the case, yeah.
Awesome, Dan. Thank you so much.
It's a great point to ask.
All right, let's move right ahead with our next case. We're going to have Dr. Ghazwan Ilyas, our interventional cardiology fellow at UT Health, present a case next.
Hello, everybody. My name is Ghazwan. I'm one of the interventional fellows currently at university, and I would like to present a case for you guys. Let's get started. So basically, we had a 65-year-old man, had ILD, interstitial lung disease with hypoxia, respiratory failure, and oxygen. He's been evaluated for lung transplantation, basically. Former heavy smoker, obesity, AAA, CKD2, some prior DVT, but it's been resolved, basically. His main symptoms were fatigue, dyspnea and exertion, and questionable, angina and whatnot. Part of it is lung disease, and he might have underlying cardiovascular disease. Pretty much labs are unremarkable, except for some stable thrombocytopenia. His workup, basically, he had a CT chest, multiple CT chests, and they've seen on 9-gated study that he has a heavy coronary calcification. His LV systolic function is preserved, so he was just routinely referred for a left and a right heart cath, pre-transplant evaluation, basically. His right heart cath numbers we proceeded first with the right heart cath, and they were pretty much unremarkable, normal filling pressures, normal coronary pressures, and whatnot. We performed the left heart cath, and the hemodynamics, normal LV, actually low LVEDP, basically. And this is the angiogram. This is a shot of the right, and you can see that there's a disease at the proximal and mid-segment. That's the AP crani shot of that. So we were thinking maybe this is intermediate, maybe this is significant, so we're thinking about interrogating that segment. We moved to the left system, and we can see some, disease at basically the other shots. Some disease at the proximal segment of the LAD and the distal LAD. The distal LAD for sure. Here I'll do another shot, which is the that shows the LAD that pretty much diffuse, calcified, and from the proximal to mid-segment, and there's a kind of tandem lesions and distal LAD that seems to be tight. So we pressure wired the LAD. We knew that the distal segment is tight, so we wanted really to interrogate the proximal and mid-proximal portion and see if that is any significant. So here are the numbers. We, of course, pressure wired the right coronary artery because we were thinking about the proximal portion that I showed you, and the hemodynamics were pressure negative, basically. IFR was negative. The mid-LAD was borderline, like 0.9, so we went ahead with FFR, and it was significantly positive. And we went ahead, we did pull back, and indeed, it's the proximal to mid-segment that was the culprit. So the plan, the strategy was really, we're going to tackle the whole LAD, like the distal area, the distal stenosis, and the proximal mid. So we basically wired, dilated the distal segment, and here we dilated the proximal segment. And after the balloon is down, the patient started having chest pain and ST segment elevations and operator palpitations. We're like, oh, okay. So the next intuitive thing to do is check on the patient and check blood pressure and everything. And we did a puff. Unfortunately, we didn't save that, but we had acute vessel closure, basically, beyond the balloon. So the next is really the third segment, the third step that we took, but basically the first initial step that we had done, we had gone back up with the balloon, we puffed again, there's no flow. So the next algorithm is, okay, we have an acute vessel closure, I still have my wire maintained, I never lost my wire. The balloon that we used was a 2.5. We went nominal pressure. There's not a lot of manipulation or anything. You just go through what could happen there. You know, is it a dissection? Is it a thrombus? Did we jail the side branch? I'm just going through all the algorithm, shouting out, hey, what was the last ACT? I know we were doing this. In every routine case, you keep asking, hey, what's the ACT and whatnot. But like when something dramatic like this happens, you start going the algorithm again. I know they told me about it, but then it was therapeutic. So the next step, we were thinking that we're potentially dealing with a dissection, and let's go ahead and stent that. So we brought a stent, just like as you guys see, and we placed it here. Of course, before putting the stent, we aggressively gave a lot of vasodilators, nitroglycerin and cardine and whatnot. And you can see some TIMI1/TIMI2 flow after that. So we went ahead and deployed the stent.
So would you guys image before doing this? Stick an IVUS down, see what's going on. Know where to start your
Depends
stent.
how acute the whole situation is. If it's, if the patient's writhing in pain and the blood pressures, you might do something. I might put a balloon in. I'm thinking also about distal embolization.
Yes.
For this kind of thing.
True.
So I might put a little balloon in there quickly, see what happens. A Suzuki catheter, so you can actually inject dye distal, and then IVUS. Those all would be great if you have the time to do it. For distal embolization, a stent is not going to be the answer. It's going to actually make it worse.
Distal embolization, the vessel closure is really at the balloon side. So
Yeah.
you would expect distal, vessel closure will be mid-LAD, distal LAD, but like at the proximal segment, immediately after the balloon,
And I would say whatever you do, favor going a little more distal with your
Yeah.
stent, longer stent distal.
True.
Make sure you cover that distal
I
edge.
agree.
So
Think about accelerating your antiplatelet therapy with
The untapped, of course, I mean,
adding Cangrel.
at this point, we added actually a 2B3A. I'm just going through the sequence of events immediately. We're thinking about that because we asked about the ACT. We made sure our heparization is on, and we added a 2B3A. We started with integraling single bolus first, and then we're proceeding. The patient was doing well.
And one of the reasons you probably dissected is there's a lot of calcium in here,
Yes.
visible calcium.
Yeah.
So imaging can certainly help tell you, hey, there's a lot of calcium. And maybe it's some atherectomy ahead of time might minimize the chances of.
And then the size of the stent,
Yeah.
Size
if
and
you're going to.
Yeah, true. So we ballooned again, and basically we decided to go for a longer stent because the initial one, we had. So this is our second stent,
Feels better.
and then this is the picture after that.
Yeah, this is not working.
It is not working. So what is next? I know you guys suggested a couple of options.
The question is, could we have started stenting distally first and then?
True.
And then how's the patient doing? If they're hypotensive,
They-
runs of VT, this is the time to start thinking you might need ventricular support and
Exactly.
hemodynamic support. The EDP was already low, so there's some risk of hypotension.
So we got lucky that the patient was doing well. There's moderate amount of pain. His chest pain was like 6 out of 10, and blood pressure was holding at relatively normal blood pressure. And
So you have time to do imaging, and you have time
yes,
to...
we have time to do a lot of
do
things.
a-
So our next step is really was to identify what's going on, because we were like, okay, we stented distally, it was relatively longer stent, so let's really study what's going on, because we have to figure out what's going on so that we can fix it. So we took a dual lumen catheter Suzuki, and it's a longer fluorosafe, and you can see we injected, and distally there's flow. And we gave runs, multiple runs of vasodilators and whatnot, and the second lumen of the Suzuki. And we realized that we have to, we might be dealing with this dissection that has been spiraling down more distally, and we really have to cover it more distally.
Or you might have covered the dissection, but there is an intramural hematoma compressing the lumen distally to the
True.
I mean, the other lesson is not to keep injecting antigrade. And
Exactly.
Again and again. And the other question is, when the flow was lost, particularly after the stent that was placed, now where do we focus? Do we start, okay, the patient is somewhat stable, but do we first focus on ventricular support or keep going? And what choice will everybody make?
Well, if this patient's stable, I'd actually try to reverse this if I could do that faster.
Faster, true.
And so, but I'm thinking right now, image or a dual lumen catheter, because the dual lumen catheter, you can inject distally.
So he did a Suzuki down
We
below.
did a dual
Did,
lumen.
go
did
back
you
to
inject contrast?
We injected contrast distally. So
Can you
I
show me that again? Because I missed.
Let me see if I can go back
Right,
here.
right, no,
good flow
Here,
back,
one
distal.
more. Can you play that, guys? Right?
just go forward.
Yeah. So that's the dual lumen
Oh,
catheter.
okay. So
and
there's
we
good.
injected
There's a good
distally.
vessel over there.
Yeah, there's a good vessel,
So
and it's patent.
I would put a stent. I would just get that
Yeah,
thing
just-
stented
exactly.
quickly.
So-
Where that
Get a 48 millimeter stent.
We brought another stent, and this is the other stent.
But you have to go down further.
And we took a picture,
Okay.
and that's how it looks. So I'm going to keep it playing for you guys to see if there's anything wrong. I know it's...
Diagonal that's missing the purple.
So we're missing a diagonal. That's a victim. That's my victim.
Okay. That's your. But that's he's alive, and it looks like
Any
the distal,
problem with the distal end
edge
of the
is
stent?
not a good-
Exactly.
yeah, yeah,
So there's
yeah.
still, you can see a dissection. If I
So you
can
just have to
point
give another
it,
stent.
there's a
Right
pointer.
at the distal
Just
end.
do an IVUS and figure out where it's nice. And
Exactly.
plump, yeah.
So, but we saw this evident on angiography that
Right
there's
at the end
a
of
dissection. So we went ahead basically and stent that. You guys can see that we had trouble delivering equipment, so we took a guide liner so that we can deliver the equipment. We inch form it and then eventually deliver a longer stent. And this is we decrease the pressure of the injection of the assist. This is an injection through the guide liner. And we have restored flow, but unfortunately we lost the flow in the diagonal branch.
Sorry. We could try to get it back, but I just
And
you're
then-
happy.
Yeah,
it's
and
alive.
of course chest pain relieved, my palpitation went away.
Yeah.
And then, this is a shot, and also we IVUS the vessel just to make sure that we're not missing anything. So the stents were well opposed and expanded, and no edge dissections or any problems. Given that the patient didn't have any further chest pain, hemodynamic instability, we thought that we just go with aggressive medical therapy and anticoagulation and whatnot, and with regards to the diagonal branch, basically at this point.
It might come back by itself.
Yeah,
Heal the
exactly.
dissection, yeah.
So really, post-procedure patient really did well. He went up to unit. We had an echo, and his EF was preserved, and he had some wall motion in the LAD territory, and he was discharged home with follow-up. So really, the first thing to do is to remain calm and we do this on a daily basis, do cases, but when a complication happens, the main important thing that you as an operator, you really have to be calm and you have to have a solid algorithm for every problem that you have to have a tutorial. Of course, it will happen to you, it will happen to anybody in this room, but you have to have an algorithm about what's going to happen and what I need to be focused on, and you have to go through this algorithm really quick and remain calm, because if you get nervous, you could just go through many steps or different steps that you could potentially go, make further mistakes, and that's what happens in the cath lab. And also, you are the person who's in charge, so it sets the tone in the cath lab. Like, if you are not calm and start shouting orders and like you're nervous, the entire cath lab and your team will start sensing that. So remaining calm is absolutely important whenever you have a complication. Never lose wire position, because if you lose wire position, then you're not sure whether, if it's a dissection, are you in a true lumen or wrong, in the false lumen, that's going to be a problem. Determine the cause and monitor the patient, as we spoke at hemodynamic support and whatnot, plus minus. This is an algorithm, from the manual percutaneous intervention from Dr. Berlakis. Really, it's a long algorithm, but the basic steps of just immediately determine the etiology and tackle that. I'm going to skip that. Types of dissections, there are pretty much 6 types of dissection. I'm going to just scroll through that real quickly. Main etiology is really injection when you're dampened, being non-coaxial, wiring, lesion preparation, which could happen in a calcified vessel, whatnot, balloon rupture, heavily calcified region, or tortuous lesions, stenting and oversizing your equipment, and or de novo like scat, like patients show up with scat and whatnot. If this happens, is your wire in the vessel? If you've never lost your wire position, it's excellent, means you're in there, so you can do other steps. If you are in the vessel, then just stent, as all of you alluded. If not, then you have to see whether you can get the wire back in the lumen, which can be quite tricky, and use you have to confirm with a dual lumen catheter or a microcatheter or whatnot to see if you're in the actual lumen. And if you can fix it, yes. If not, you might need to call your friend, the surgeon, see if they can fix it for you. And any discussion or questions?
Good job.
It's wonderful. All right. So next we have Dr. Almamani. He's going to show us his case on TAVR.
Okay. Well, I couldn't think of a good topic for this talk. It's flying valve, so you guys know exactly what it's about already.
Plane or flying?
Flying, sorry. So
There's a flail too.
it was. I actually wrote it here in the backstage. I was like, let me change the dial on 8. So it came out like this. Anyway, so we have a 64-year-old patient with history of bioprosthetic valve stenosis. So she had 21 millimeter magna E's in 2014, and that valve degenerated pretty quickly. The patient also has severe COPD, obesity hyperventilation syndrome, type 2 diabetes, hypertension, and she is significantly symptomatic with her echo finding showing a gradient of 42, valve area 0.89, her dimensionless index is 0.2. So she was seen in the multidisciplinary valve clinic for consideration of treatment. The discussion was this patient, after reviewing everything, will be high risk for surgery given her respiratory comorbidities and her body habitus. So I'm just, gonna kind of cut to the chase to show you here what her CT looks like. And if you look at the top, you see that her ascending aortic dimension is 4.7 almost. The sinuses are generous at 38 and 41. I'm sorry, this is the sinotubular junction dimensions, and also sinuses are generous between 32 to 37. And coronary heights were low, but the sinuses are just huge, and the valve is very far away from anything. You get a sense of this kind of horizontal aorta, and we anticipated that we might have some trouble crossing with the valve. I'll walk you through the case, but this is also how it looks like. You see here, this is by the annulus, this is by the sinuses. The coronaries are low but far away from the bioprosthesis. And for people who don't do TAVRs, when we do a valve-in-valve, we look at a virtual valve to coronary distance. So we put a virtual valve here and measure this distance to estimate the risk of coronary occlusion. And in her case, it was very far away, that we're not concerned about that. You look here and you see the sinotubular junction at 40, almost 42 and 40 millimeter in diameter. So here we had a multidisciplinary discussion, and we decided that we want to give her something. She's young, but she's prohibitive for surgery. We're going to give her something that can give her what we think will be the best gradient, most durable. So we think about a supraannular valve. And in this case, we did choose to put a 26 millimeter Evolute Pro and do bioprosthetic valve fracture, is when you put a high pressure balloon inside the surgical valve and try to break it to expand your TAVR valve to the best possible to get the best gradient. So positioning of the valve during the case was difficult. We had to actually take our wire out and snare the wire, snare the nose of the core valve, pull it to kind of get it into position. We actually changed from our Safari wire to a Lindequist wire to get more support and try to get to a coaxial. And the valve was deployed. We left a few millimeters below the surgical valve because we want to do fracture, and we don't want it to be very high that might embolize a couple millimeter below. And fortunately, this happened, and I'm going to take a second here to talk about why this happened. This is a balloon on the Lindequist. We haven't inflated the balloon yet. What happened is I pushed the balloon. When I do my bioprosthetic valve fractures, I like to have the balloon more ventricular, but the Lindequist wire was too stiff and not helping me. So it was like, hey, let's walk it out. Let's put our Safari back in, and I want to position it in a better place. And simply just walking a balloon that was never inflated, just walking it back, popped the valve out. And retrospective, now I know what have caused this, but I don't know, do you guys have any idea what might have led to this here?
Well, it looks like it caught it looks like it caught the wire up top, but it should have been firm enough that that bumping the wire like that wasn't going to bring the
Exactly.
wire. Because you could see as the top thing kind of catches.
It did
so
catch.
the question,
But we see that.
We see that, and it
you
usually
walk it out,
just
you
goes
go
on
in,
through.
It goes
I agree.
on. So
and so the valve is tenuous at its place to start with for that to do something
It clearly
like
wasn't
that.
seated.
Yeah, right, and for whatever reason, whether it's too big, whether it's too,
if you look carefully, the
small,
valve
too
is not
small,
too
one of the two,
shallow.
exactly.
There's a few millimeters below the ring, and it has all the leaflet length to hold into it. Now, I tell you what happened here. It did catch to the valve, which sometimes happen, and you still can walk it easily.
Right.
The problem is the outflow of this 36 core valve. I'm sorry, of the 26 core valve is about 36 millimeters, so it's not even touching the wall of the
right,
aorta.
just too small. Yeah.
So you tip it to the side, and what happens is this valve just pops
Too
out.
small is what I mean, yeah.
So that's the issue. Oh, so how would you manage this? I mean, I know we have a few structural.
Paul, what do you think?
So, well, I probably would have used an Edwards to start with.
Sure.
I mean, I don't
I'd say the same thing.
I don't really like the horizontal. I learned my lesson on that. The horizontal routes are really hard. The problem here, it's been a long time since I had one of these. I had definitely had this happen, but it's been a long time. The problem is, I don't think you can. The way you have to do an aortogram to see where you are, but I think you're probably right up against the head vessels there. I don't know that you're going to drag it up very far. It may be up far enough. That's the next question, because you want to put a valve in. I assume it's going to be an Edwards valve now,
Yeah.
if the people are around to help you. but they usually are on valve day. And then you
They're helping Dan, so we can,
Exactly.
we can steal them away.
but the question is the coronaries, but they're low, so you're probably okay.
Yeah.
You probably just have to put an Edwards valve
So-
through the other one.
So
and-
short answer, snare this as high as you can.
Yeah,
Right?
but it may be high enough already because that.
And the aorta's
yeah.
pretty big, so
The
is it
aorta's
floating up there?
46,
I mean, you said
47.
47 or
So
something?
let's
Those
go
guys
back
to
to
begin
this
with.
picture. See what goes here is the aorta is pretty big until the arch, and it all of a sudden goes to be too
Yeah.
small.
Well, you don't want it to go
That's
across the
definitely
big
one of the
vessels.
concerns, for sure.
But remember, it's not going to be a competent valve. It's going to leak all around it. It's going to fill the vessels okay. If you manage to get it to the arch and it's across the great vessels, sure. I don't know what the risk of.
I wouldn't put it to. Well, I don't think you have to pull it through the arch. I don't think you want to do that.
Okay.
I don't think so. I mean, look, how many
Wait, if you
feeds have we
was
done?
it floating?
Maybe
Because
you
the
did-
Was it floating?
is 47 millimeters.
Right. So it's not going to hold unless you get it to a place where it can hold it, right?
yeah.
So you have to pull it.
Yeah,
you
but
have
the
to.
valve almost looks like at that point where it gets narrowed.
Yeah.
So it's going to be hard to pull.
So the consensus is basically try to pull it where it can be stable, and put maybe an Edwards valve. And
You might want to, when you're done, you might want to stent open the leaflets. Some people do that.
great
with it,
consideration.
yeah.
Yeah.
Because then you don't.
Yeah,
You
but
might
that has
have-
to leave. I'm not
yeah.
sure what to do with
Right, that's
leaving
why
that up there, right?
well, if
Yeah.
you have a stent big enough, you can stent open the leaflets of the core valve or the evolute.
Right.
So what kind of stent would you use?
You have to use I guess a Palmage stent. I usually call Curtison at that point, my peripheral guy, and say, and big stent. It's got to be big. You have to have a big enough stent,
Yeah.
which you sometimes don't have.
Like at least, I don't know.
And I don't know if that's necessary, but
Yeah.
he likes to do that when we have these
Okay, so
horrible things.
let's see what we did. We
Okay, so
deployed
you
the
snared it.
S3. You see my S3 is actually low because I was worried, and I fractured the surgical valve. And this is what it looks like. And
Wow.
I mean, at this point, the AS is treated. Now, what to do there? I did snare it, pull it as much as I can. And now,
I
the
was
thing
worried
is,
about the head vessels there. I mean,
yeah, so the head vessels, I don't know if it didn't show here, but we do see them filling okay, pressure is okay in our line. We sometimes, this is a general anesthesia case, and because of BVF, so we also have pulse oximetry and it looks okay, so we're happy. Now the question is, now we're gonna leave that there and just, call it a day, right?
And it really
Well,
shows how big this aorta is with the aortogram relative to that valve.
can you
You
put
have
up?
blood flowing all around.
I mean, you've done this stentoplasty on the bioprosthetic valve now, and you've already fractured it. Right? Yeah.
It's fractured, it's open, the 23 is fully.
Is that a long-lasting way to treat a bioprosthetic valve? I don't think so. I mean, can you put a Edwards valve in there?
There's an S3
Yeah.
valve
Oh,
in
I'm
it.
sorry.
Yeah,
I thought,
yeah.
That's
You put an
already a
Edwards
valve.
There's an
in there.
S3 valve.
We skipped that part.
I skipped because I want to
Okay,
get
I
to
kinda
the
missed that,
management.
okay.
Yeah,
So that's what I would have done.
No,
And then the question is, what do you do with that thing up there in the arch?
Right. So we put an S3 valve in it and we fractured it with
Okay,
a
fine.
22 balloon or something
good.
like this.
Good.
And now the gradient, we measured the gradient was something like 10, which you expect with a valve and valve case. So now what do you do now? Just release this where it is and just basically, if it's stable, you call it a day, right? You're done.
I don't, what would have happened if you didn't? Why did you have to pull it back?
It's just so big.
Because the aorta is just so big.
It's huge.
It's huge.
That probably wouldn't have stuck. We probably would have gone that way.
It would have migrated
Okay.
anyway,
You think it would
maybe.
have gone by itself there?
Unpredictable.
You'll see.
Because you were,
So because even after I
Okay, more
pulled
to
it
this.
back and I lifted it a little,
That's
this
why I
is
would
what
have let
happened.
go just to see what happens. And
This is after snaring the
that's
two
what I'd be worried
taps.
about. I'd be worried that's exactly
So
what's going to happen.
flaying, I don't know what kind of valve. You can call
Wow.
it whatever.
That's pretty cool.
It's going to flay the aorta open.
it's hard to leave that, isn't it?
Notice the 3D rotation.
Isn't there a heart surgeon here? Can someone take that
Wow,
out?
that's a pretty picture, though.
So this thing is rotating. We're kind of discussing what we need to do. We try to snare both taps at the same time and pull them as much as we can to stabilize it. Still not stable. phoned a friend and called, of course,
Yeah.
called the surgeons to the room. The surgeon's like,
Opened it, yeah.
she's not going to make it if we open her chest. She's very, very high risk, prohibitive risk, basically. Called the vascular surgeons, like, do you have any ideas? And they start talking about, bypassing the aorta. Like, guys, it's not affecting the flow to the carotids or anything like this. So what do we do here? And we even called, some of our friends, and somebody was telling me,
another cool one.
snare the two tabs.
We called Marvin in the
Marvin
middle,
A.
in the middle of this.
and then he was like, put 2 wires through the other sides and have 4 points of snare and try to pull it. I was like, I'm not gonna dissect the aorta.
You could dissect the whole aorta.
Yeah.
Exactly. So that's the only thing you can do is put it.
What kind of endograft?
Most of them are covered, right?
Most of them
So-
So a stent, like I say, a Palmaz stent, a big.
How big you can? So the thing is, this goes
I
from
don't know.
40 something to 25
Yeah.
after the great vessels, and the outflow is 34. So it's somewhere in between. So
You can tailor the stents nowadays, that you cut the stent to the measurement, just like that, ascending aorta, rather than
to just stabilize
What
the
about
end.
putting another core valve through that?
So the thing is, again,
it's so
so
big, it's
where are you going to
46.
stent from? Because you don't want to impede the
Opposite
flow
wall, right?
from that, and the stent is not going to be opposed unless it's 46 millimeters, 45 millimeters, right?
I mean, we need to see the measurements at the beginning. You have to stent from like the sinus, the SCJ.
So 4.5 centimeters.
37, right?
Yeah, oh, down is sinus 37. The sinotubular junction is 41 by 40 or 42 by.
Biggest bore stent is like, I think 42 or something.
Yeah,
But I mean, just an idea.
it's a good idea.
And we have coronaries to worry about too. So.
Yes,
And you use multiple snares to pull or just one?
2 snares,
Yeah.
2 taps, same
on
time.
top, one on
Pull them
bottom.
as hard as I felt
Yeah.
comfortable.
We've done it,
And
we've had to
still
hook up on the
was
top
it-
one and pull down.
So what happened
Try
next?
to bend
Yeah.
it that way, but.
So
you
next,
go
I
to
asked my
25.
vascular surgeon, do you have any open cell stent that's huge? And he was like, yeah, we have that dissection stent that's so often it's not supposed to do anything, just hold the dissection flap. I was like, how big? It goes up to 45. I was like, great, well, let's try that. So we take a picture, we see where valve is here, snared again. We see the 2 snares. I'm snaring one tab now, and then take this pigtail. The reason I do this, I want to snare it up where it's basically occupying the aorta because I want to again gain access through the valve, to stent the leaflet open. So that's all our discussion. We found this stent with the open cells. That's 45 millimeters, and got it through with this, continuously snaring the valve to make sure it's in position, and then this is an open cell stent, so it's not going to cover any great vessels. It's not going to cover the valve, even if it, touches the valve. And there you go. Wow.
Wow.
All right. Well, and this is how it looks afterward. You see a flow.
The valve's not moving anymore.
About a couple hundred grams of metal and
Paper.
So that stent's designed for aortic dissections.
right, and it's open cell.
Wow.
So it just grows.
That's a good
and
zenith.
Huh?
That's good to know about.
Yeah.
I like that.
Well, I guess part of having these talks is just to learn. How
Wow.
So, patient did well. She was discharged after a couple of days. Her symptoms improved. And, we did a CT follow-up, on her 30-day follow-up. And you can see the great vessels filling nicely, no issues. Thank
You
you.
tell her she got 2 valves for the price.
She knows. I know who's that.
All right, thank you. The next case is by Keith Wynn. That's right.
Hello, I'm Keith Wynn, and I'm a Methodist physician. You present, Dr. You present about CABG versus PCI, so I have a presentation about that. So this case is an 85-year-old gentleman who was at an outside hospital. He has a history of a permanent pacemaker, hypertension, hyperlipidemia. Came to an outside hospital with a non-STEMI, so he had a cardiac catheterization, mild left main disease, but severe three-vessel coronary disease. He had a subtotal mid-LED. The circ has a very proximal severely calcified lesion, and he has a CTO to the RCA2 as well. His ejection fraction was 40%. This is his EKG, of course, paced rhythm. So this is his diagnostic catheterization. You can see here on the left side, you got the auriocranial. The mid-LED is subtotal, proximal. You can see the heavy calcification in the proximal LED. On the caudal view, you got severe circumflex lesion, also heavy calcification too as well. There's also several obtuse marginal branches that comes off. There's a ramus that is subtotal. And here's another view. You got a severe circ lesion and severe LED lesions. And this is his RCA. RCA is a CTO. He has collaterals coming from a conus. So, you know, when...
Bypass surgery.
So he had a heart team evaluation. Yeah, that's what we do here in San Antonio most of the time. You know, but I think it's important that, you know, when we look at the data and we evaluate the patient, and we want to do what's best for the patient, but the things that we forget about is what the patient wants. You know, something I just found out was when one of my colleagues wrote down, texted to me GOC. We wait for the GOC. I'm like, what is GOC? So goal of care, the goal of care of patient in terms of what they want to do. So I think it's important that if the patient, you know, who's like this guy who's 85 years old, you know, he's not looking for improvement in long-term survival, but more like quality of life. So the surgeon saw the patient, but because of his age, he's frail, targets didn't look that great, they turned him down for surgery. So he was transferred to our facility for complex PCI. Because of his low EF, he got multi-vessel ischemia, got a subtotal LED, a CT on the right. His EF is down, and I'm probably going to do atherectomy, some kind of atherectomy devices. So we opted to do an Impella. 2.5, his blood pressure is good, so don't necessarily have to do a CP. We placed in a 14 French sheath. With a 14 French sheath, you guys probably all done it before. You can put another sheath in. There is a sheetless guide that you can use without using a sheath. It's called the power back. So it is a 7.5 French guide. So I use a power back to start fixing the LED. So after the Impella was placed in from the right groin, we did a single access. We put a power back 3.5. We went in with a microcatheter and a jacketer. First, you get there with your workhorse wire. So once I got there, I got a jacketed wire. You know, it crossed that short CTO subtotal pretty readily. So we did a tip injection just to confirm, because after the microcatheter was across, I did a little puff, didn't see any distal flow, so I did a tip injection. So you can see here the wire is in the distal LED, and we decided to go ahead and do a rotablation of the proximal LED and the mid-LED as well. So this is after we rotablate the vessel, and I tend to IVUS pretty much most of my patients, if not all the patients, before I stent. So we balloon, and then we IVUS, and then we stent. You can see the LED. After, I think it was 2 stents, when the proximal LED is a 3L vessel, the mid-LED is the 2.5 vessel. So, we got, well-expanded stents. These are drug-coated stents. So then, next vessel we want to do is we fix the circ. We went in with a microcatheter and our workhorse wire. I thought it was going to be really tough and heavy calcification, but luckily, we got through pretty readily into the obtuse marginal branches. So we ballooned, and we stented that OM, and also we stented the proximal circumflex too as well. So this is what it shows after we did the intervention. See, like again, we IVUS. You really should IVUS, your intervention, because I went to the CTO summit this year, and the 5th generation drug-eluting stents is actually the current generation drug-eluting stents with IVUS. give you the best TLR and restenosis rate. So really want to do is well expand your stents. So after we fixed the LED, the circ, I mean we didn't use too much contrast or radiation, so we went ahead and do the CTO. We want to be as good as the surgeon. We want a complete revascularization, so we want to complete what we're going to do. So this CTO is it's a short CTO. It has an ambiguous cap. You got this conus coming off. You couldn't really see where there's no like an entry point. So I put this is a JL4 guide. Not going to give me a lot of support. So I put a kind of workhorse wire into that small branch, and that collateral is initially the collateral it is a conus. There is risk of perforation with the collateral. So I went in integrate first. See if I get lucky and find a little channel or something like that. But using the hydrophilic wire, you couldn't really find, everything was kind of bouncing off. So at this point, we use a stiffer wire. What the plan was to do is, if you look at the CTO algorithm, you do, when you can't penetrate a cap, you do a stiffer wire, you do scratch and go. So I went in with a guide second wire. It's a pretty good penetrating wire. Got into the proximal cap, and you can see on the right side the wire dances with the heart. So I'm pretty happy. I'm in the architecture of the heart. So like, well, at this point, I should have switched to de-escalate to a ejaculated wire, but I got a little happy. The wire was going pretty easily. I'm like, well, let's go a little bit further. So of course I went a little further and I did ejection. You can see the guide wire went somewhere on the left side.
So Keith, you don't worry about antegrade injection in this case?
Well, I mean, there's no control. You can't get, the cloud is coming from the conus, but I haven't ballooned anything, and my microcatheter hasn't gone in there. So I wasn't worried about dissection or anything like that.
Keith, I mean, I know at the beginning you said this is 85-year-old, goal is not for quantity of life, just improve his quality. Did you, at any point you thought about stopping after fixing the LED and the circ and leave the CTO alone in an 85-year-old?
No, because my CTO intervention is, we've done close to 600 cases. We probably maybe this year we're 100% successful. We're less than 1% complication rate.
But
so
you yourself said that the goal was to make him symptom-free in an 85-year-old.
Yeah, we also symptom-free. This could be his ischemia too as well.
But how do you know? You just fixed the LED circ.
Well, are you going to tell the surgeon when they do CABG, they're going to fix the LED and the circuit lead the RCA?
This is a thing about the consenting thing.
Yeah, so.
You're always going to find somebody who's going to tell you,
Right,
it's a CTO of the right, it's been that way
Right.
for
I
a
mean,
long time, did a great job,
right.
why bother? But you got
So-
the impella in.
So in
figure
reality,
with that.
if you don't do CTO, leave it alone and send it to me. That's what you should do. But anyways, so we decided. So at this point, you look at the algorithm. Okay, so the wire went somewhere. This is a complication talk, so you guys probably know something will happen. So looking at the algorithm, you got if you go integrate, you can't go further. You go through the algorithm. You can go retrograde. So I went retrograde. I went through the conus. I went through the conus. You can see on the left side, we went through the conus. We used a pseudo-3 and a caravel catheter, did a tip injection. And then at this point, we're like, hey, everything good. Put the wire back, let me set up my reverse card and finish my intervention, right? So then the wire, the retrograde wire went through into the aorta, and then it went up to the right subclavian artery. And I put a radial sheath in the right arm and then snared the wire, the retrograde wire, and then I got my JL4 guy into the RCA. And at this point, we externalized and we started our intervention. So after we balloon, you can see there's a blush of contrast coming out in the mid RCA, right where the guy wire was. But so what would you do at this point? You got blood pressure stable. You saw that. What would you guys do?
Well, so you have some tamponaded. It's hard for me to see
Yeah.
it.
Inflate the
Tamponade,
balloon and
echo
with
as
some
well.
balloon.
Yeah, so at this point, you put a balloon in there. First thing you do is put a balloon in there, you stop flow. But the good thing about doing CTO is, well, good and bad. When you balloon this, there's always there's still flow retrograde into the distal RCA. So you can leave the balloon up there for like an hour and there's still no problem. So I put a balloon up there, I call echo, we got fluids going, pressure's available. I told them to get a paracarditis tray ready just in case something happened. But so
Put
the
a covered
wire,
stent in, you could even coil it all closed back
yeah,
again.
right. So
That's what it started with. I mean,
so
it's
balloon-
probably
balloon,
didn't need to be done in the
then-
first place.
balloon then stent, or balloon then cover stent, or balloon and see what happens. So since this is since I got the retrograde wire in a different plane of the antegrade wire, a lot of time when you go retrograde, you're in the different plane, and you stent the retrograde wire, you actually tack up the perforation. So I mean, that happens actually a lot. But in this case, this is after, this is the balloon tamponade of the perforation. This is the type of perforation. This is a grade 3. So we actually end up stenting the vessels, and you can still see a little blush in there.
Yeah, that's all right.
Patient blood pressure remains still as stable, but steadily going down.
Anything on the echo at all?
Yeah, so we got echo in there, and there was a small amount of pericardial effusion in the RV area, which was kind of compressing the RV, and his blood pressure was coming down a little bit. But so we decided after we ballooned, after we ballooned and we stented, and I did a prolonged. This is the one on the right is after prolonged balloon inflation. That was still bleeding, so I got you can't just leave it there. So I am putting a papyrus cover stent in there. Where the perforation was. So when you try to put a cover stent within your first stent, a lot of time you're not gonna. It's hard to deliver the stent. The fabric's gonna fall off. So we went in with a guide extension. The guide extension does two things for you. It blocks the flow, antegrade flow, and then you can deliver the cover stent. So that's what we did. We used a guide extension. You can see it's unsheathing. You can see it's coming back. So so we stented with a cover stent, and then his blood pressure wasn't that great. He got some effusion, so I went and put a pericardial drain in from the apical. We removed 200 ml, and after we removed the fluids, his blood pressure got better. And we waited. We gave protamine, and we waited, maybe 20, 30 minutes, and we weaned the impella, we explained the impella.
Did you dial down the impella flow?
That's exactly what I was
because
gonna
the problem with tamponade is you don't fill the ventricle, and so,
Just to increase the preload.
yeah.
Yeah, we dialed down after when we weaned. We have our techs, impella reps. They're pretty good about managing the impella at that time.
It was only at 2.5 too, so.
Yeah, it's only 2.5. It's not a big flow. So we weaned the impella off. We took the impella out. We closed the groin with the manta, and the following day we removed the drain from the patient. This is his echo. A couple of days later, you can see. The paradoxical septal motion from the pacemaker. But I thought his EF is better than 40%. There's no pericardial effusion. So for the fellows, if you see a wire perforation, first thing you do is put a balloon back in the vessel and then tamponade up. There is a perfusion balloon from Teleflex Vascular Solutions called the Ringer. I guess it's coming out where you can perfuse the vessel at the same time. But when you're dealing with CTO vessels, there's collaterals. You don't have to worry about ischemia. When the vessel is big and it's tortuous, it's hard to you don't want to take the balloon out. You can't be if you're not very quick at it, get another access. You can do a ping pong technique. Try to wire the vessel when the balloon is down, and then you can use that the other guy to deliver your stent. And the other thing too is you don't want to stop heparin when you have your wires and balloons in there. You can clog up the vessel, and that's the last thing you want to happen. Use the guide extension to help stop or slow the bleed and deliver your cover stents. And be prepared. Have echo in your room. Be prepared for pericarditis. Be good at it. Do it often when you have a patient that your partners needed pericarditis. Give IV fluids. So in summary, we patient with severe vessel coronary disease. We have a heart team, but complete revascularization. If they're not a surgical candidate, we can do complete revascularization for high-risk complex anatomy patient, having the right tools and experience. You have to have a complication card, part of your CTO card. We have snares, we have cuff stents, we have pericarditis, we have all that stuff for this type of procedure. Always think about mechanical circulatory support if a patient has low AF and high ischemic burden. IVUS, to me, is very important. That's your 5th generation drug-coated stents, and you want to size it correctly. Because the last thing you want to do is put a lot of stents in and they come back with restenosis. Have a plan for access. If the patient is older and you can do single access, and go ahead and do it, especially if you have the tools for it, like the sheetless guy. And if it comes into a complication and you need help, just call somebody. They can come and help you.
Good case.
Yeah.
Okay.
Nice job.
Can I ask a question?
Yeah, please.
To Keith and panel. You brought a great point about reversing heparin when you have wires in and all that. Definitely, do that. But, classic teaching or for our interventional fellows, we never reverse heparin after a normal PCI. So when they get into practice and they're going to get their first perforation, they're going to ask them, do you want to give heparin? And he sealed it, put a covered stent or whatever. But when do you want to give heparin? Do you want to give heparin before you try to tap it, or you want to try to tap it first, then give heparin? So I don't know. I see what you guys think about that.
So, when we do a complex, when we do an elective PCI, we always load them with aspirin, Plavix, and Brilinta. So I'm not worried about reversing heparin when they're already preloaded with antiplatelets.
The issue is we
about
were all taught to, to give protamine as soon as we see a perforation.
Right.
But that, it's kind of got out of style now because the concern is you get clot in the pericardium.
Right.
And
Clot in the
you won't be able to
pericardium,
you won't be able to
clot in
get it
the
out.
Right.
That's the problem.
So my point is, if your patient is in tamponade, don't give him the heparin first.
Yeah, that's the point.
Tap
That's
him.
the kind of new teaching, yeah.
Then give the heparin. That's the point I was
Protamine, you
getting to. So because you can form the blood into coagulum and then it's not going to come out.
Yeah, I mean, I think the correction is
Yeah.
don't give them
Protamine.
protamine.
I'm sorry, the protamine. So
Definitely don't give them.
absolutely give him more heparin.
Yeah.
Tap it first and then get it out and then give him the protamine, because otherwise you form that tamponade into a coagulum that you're not going to easily get out, and you get in a worse situation.
And even before you get to the pericardiocentesis, you want to tamponade your perforation, put a balloon there, inflate it, leave it alone, and then you can still continue maintaining your therapeutic ACT, and then you can do pericardiocentesis. The key is to put a balloon tamponade your abaxial perforation so that your effusion is not getting bigger.
Just one comment. Corneal perforation from CTO bench is very low, like 0.5%. So there's a complication talk, so I had to bring up a perforation. But just because they have a CTO and you guys, patient, if there's a lot of ischemia and the patient has a CTO, they're symptomatic, you should try to fix it. If you have a 90% lesion, you're gonna leave it in and do, if you have the experience to do it, you should do it, especially if they're symptomatic, they have ischemia.
I'm just real curious from the panel, and an octogenarian with multivessel disease, low EF, where you're going to do some kind of intervention, what do you guys quote them as their risk up front? I think this is where we have trouble sometimes, is giving them a number. What's the chance that something bad will happen?
It's hard to give that chance. No, it's hard to give them a definite risk, because when a complication happens, like for this patient, if something would have gone wrong, then that's, for them it's 100%, although you can give them a complication risk of each procedure that you're going to do, but when you're summing it up, you're doing it multi-vessel, so that risk multiplies it that many times.
What the risk of what? Of death? Or,
You know, I mean, 80-year-olds don't,
so
anything can
what-
happen,
You know what
right?
I do is I say, for a typical case, like even if it's a diagnostic that's going to lead to a PCI, I say, look, the usual risk is about 1 in 100. I say 1%, and then I say 1 in 100, because they don't even know what that means sometimes, 1%. And then, but if somebody referred to me with a harder anatomy, I'll say, and I would say yours is more like 3%, which sounds really low, but it is 3 times the usual. But still, the risks are pretty low with all this. I think that case was pretty, that right coronary, you could easily get into trouble with that right coronary. I would have waited on that and made sure you needed it. I'd be honest. I just think that was pushing it, and particularly going through the conus branch to get that you can get it. you can get a really serious perforation of the you know, and I think that the question is it indicated, does the patient still have symptoms with this chronically occluded right coronary artery? That's, to me, the issue.
I think you told me once the right coronary doesn't matter, right? Yeah.
Well, I just think,
think you mentioned that.
all the CTO operators go crazy about the right coronary. They always, I mean, the right coronary is the one that people live forever with when it's occluded, and I know all the CTO, you know, zealots just like that because that's the one that's usually occluded, and I just wonder if it's worth putting the patient at life, you know, you get a little older, you get more and more worried about. You realize just how bad life can get real quick.
Absolutely. All right, we have one final case I want to jump to. So Bader, you want to join us here? So Bader is our interventional fellow. He is going to present the last case on road ablation.
Good evening, everyone. My name is Bader. I'm going to be presenting a case that didn't go smooth in the cath lab. It's the second time for me at SAFE, so I'm honored. Thank you so much for having me. So I have no disclosures except that food. I didn't pay for it tonight. So our patient was a 62-year-old male, had a past medical history of coronary artery disease, had a CABG in 2015, and has history of heart failure with improved EF later on, was low, improved later on. Type 1 diabetes, diagnosed at the age of 14 years old, insulin dependent, almost like for 50 years, hypertension, dyslipidemia, GERD. He was referred for ischemic workup because when he was following up with his cardiologist, suddenly his EF dropped from the 55% that he had to 35%. New motion abnormalities on his echo, and also the stress test also was abnormal. The patient didn't have that typical angina, I guess, if he's diabetic or the type 1. I wasn't expecting him to say I'm having chest pain, but he started having dyspnea on exertion. It could be from the heart failure, it could be like angina equivalent, who knows. He didn't have any other surgeries beside that CABG, no drug allergies, doesn't smoke tobaccos, ethanol, or doesn't drink alcohol, no drugs. His mother was also type 1 diabetic, and she had history of early coronary artery disease. His physical exam wasn't revealing even volume status. There's no much of fluoximetry, edema. EKG showed inferior infarct, some nonspecific ST changes. Labs also like CBC, kidney function. Thankfully, it was not that bad. His A1C 7.5 for a type 1 in his age, it's acceptable. Lipid panel LDL is 58, it's tolerable. I guess that's the new changes in his wall motion. Sorry, I didn't put the images for the echo. I don't want to bother you since it's an interventional presentation for him. So you can see that his inferior and posterior wall become kind of worse when his epics become almost dyskinetic. So the top one is his old echo, and the lower one is the newest one. So the EF dropped, and he had dual motion abnormalities. The epics got worse, mainly in the posterior lateral as well. So for some reason, I guess his cardiologist decided to do ischemia approach, see if there's anything to retrieve. This is a nuclear images. So the one in the middle is the rest images. The one on the top are the stress, and the one at the bottom are the prone. So the patient showed some anterior reversible ischemia. The inferior wall seemed like fixed defect or like fixed infarct, nothing really to fix. But the one at the top, the anterior interlateral wall, showed some reversible ischemia that can be maybe fixed and can maybe relieve his symptoms, improve his EF, prevent him from having ICD. It's all possibilities. So we got the patient to the cath lab. It was a femoral axis. He has a previous history of a pretty bad spasm in his radial artery on the previous cath, so we skipped the radial arteries. And he also had a CABG. So when we shut the native arteries, his left main didn't appear that much disease, but the ostial circ, significant disease, and the LAD, maybe it's not the best shot to show it, but it also had disease distally with no competitive flow. So we got a sense that his lima could be down, and we didn't see any graft filling from his native arteries as well. Again, this is his LAD distally, not filling much, and there's no competitive flow from the lima. And the right side is kind of subtotally occluded, maybe partial filling, and anterograde, and also again you can't see any competitive flow this view. And we did the Lima shot atretic, not feeling much, not really serving much for this patient. And we tried really multiple engagements with the venous graft. I didn't put all the images for you guys with all this stumps and occluded stumps. Eventually we just did a official root angiogram so we can document that those veins are gone. And here what to do, surgery were consulted and they said definitely this patient is not a candidate for a redo. So he was not a surgical candidate. Now what do we do? He's on maximal anti-anginal therapy. He's on more than 2 anti-anginal medications. He's having symptoms, his EF dropped. Do we just do medical therapy? Do we intervene? Any suggestions? Would you leave him alone?
If you do medical therapy, it wouldn't be a complication.
That's true, that's true. So,
You
yeah.
gotta do something.
Yeah, and we had to use an Impella too. So, you know, like I guess me and Dr. Wynn are the only people to use the Impella today. So, we got an Impella 2.5. His EF is low, and also we elected using 2.5 Impella. One, the same, like the same stick axis, 14 French and 7 French hydrophilic axis, and also we decided it was pretty calcified on IVUS, so we got a workhorse exchange over microcatheter. We rot ablated the LAD to make it, you know, more patent. We ballooned it, stented it, improved the flow over there. The LAD, you know, PCI didn't have any issues. But then we tried to fix the circ. It was the tighter lesion. You know, we started ballooning, but it wasn't healing. You know, at that time maybe we didn't want to rot ablate again. The LAD rot ablator was 1.5 burr, but then after, you know, all this trial of ballooning the circ and the lesion wasn't healing much, we decided to rot ablate the circ as well. And what happened is...
So is there a point after balloon angioplasty that you guys don't rotablate?
We're moving to shockwave. Once we've done balloon, we'll go to shockwave.
But specifically for rotablation, do you say, you know, if I go 2.5, 3.0, aggressive, high pressure NCs, then I'm not going to rotablate?
I mean, you want to decide that early on and
No,
try
but,
to avoid it.
I know,
I'll try to
but
avoid
you know,
it.
once, so you try to avoid it.
Yeah.
Yeah, once I start to balloon, I get...
Unless I see a very big obvious dissection, I think it's okay. You'll have micro dissections, but rota will cause dissections too. If you have the wire down the lumen and
From the audience as well? Oh yeah, sorry. Go
So if you have the wire down the lumen and there's flow and there's no obvious dissection, I think it's fine.
Anyone else out there would, you know?
I was before I rotablate to see what I'm dealing with it. I mean,
So see this after ballooning, nothing really changed. It's still like pretty...
yeah, but sometimes the dissections you may not pick up, and IVUS can pick up stuff until you want. IVUS can, I mean, one thing Dr. Bailey has talked about is IVUS keeps you out of trouble. IVUS will tell you what's going on.
Problem is,
Yeah.
yeah, that was one go.
Yeah, I mean, you know, sometimes even getting the IVUS down is challenging.
It was
right?
challenging.
Agreed.
Right.
Yeah. So,
Expansion was pretty good.
yeah.
I think shockwave is...
But still, I guess post
If it's
the
an
ballooning
easy, you can
didn't
get it
really
If you can get it there.
I really...
give us like what we wished.
And
So,
I've done rotablade for 30 years. I love it. I think shockwave is...
uh-huh.
Let it heal 6 to 8 weeks and bring them back for rotation rather than rotate now. They have a fresh dissection. That's actually what I do.
That's sort of been the traditional approach, right? Is
Stage it.
not push it.
And if I don't see a big dissection on IVUS, I would IVUS.
Yeah.
Guide me in that decision making. Should I
But when we actually, reviewed the case, before we decide to stop, reviewing the symptoms, the stress test, we thought that the culprit, before we intervened, that most likely the CERC.
That was my question.
Yes.
Because on your echo, you showed your distal septum and distal apex were dyskinetic. Why did you go with the lady first? I'm sorry.
Yeah, because
I
he's.
was in the surgery.
Yeah, because his schema was like interlateral, more like and also posterior, and the distal AD was gone. Like there was no way we can.
And disconnected.
Exactly.
The apex is disconnected, so there is no reason to change that.
Mm-hmm.
Still a lot of septal collaterals providing collaterals to the right and the circ as well.
Yeah, but the right is fixed on your disc. There's no schema. It's not fixed. It's straight.
No, but there's still a lot of collateralization.
But it doesn't matter. The porphyria study showed that inferior wall is fixed.
And the diagonal as well. So there was felt to be some reason to at least fix the mid-proximal.
But if I
So what happened next?
But I mean, the complication is not mid-prox LED, so let's move on.
Yeah, so, we decided to rotablate the circ as well. The LED went fine, but then the rotablator got stuck basically in the circ. And here, when you hear the rotablator going, and then stop working.
A little higher pitch. Go again.
Yeah, exactly.
And then here the rotablator stop, your heart stops, and then okay, what happened next? To me, it was the first time I see it in person. I didn't, I just watched videos
That's
for
when
it.
we all turn and look at JG, right?
Yeah, exactly. What do we do?
And my dad is a dentist, and when he drills teeth, the sound doesn't stop until he's done. Here we're not done.
The teeth is gone.
We were not
Drill
done with
gets
that
stuck in
search,
your
so
tooth.
what do we do here? Any suggestions on how we get that burr?
Pull it really hard.
So just show of hands. If you don't want to raise your hand, you don't have to. Who's had a burr get stuck before on them?
Oh, well.
Yeah.
So it's not that uncommon.
Yeah.
Was it a 125?
1.5.
Okay. Yeah, because I don't ever use a
I
125
avoid
anymore.
125s.
It doesn't make a difference, and that's the one gets stuck if it's going to be. It's always the circ that gets stuck. It seems.
Here is to try if you can get another wire and a balloon and balloon it to release that.
I must say, when I was training, my attending at the VA would do ad hoc road on the fly because it's the VA. And the only burr you would always start with was a 125. Never got stuck.
Yeah.
The only time I was with a burr that got stuck was with a visiting attending who never does rota, maybe twice a year, and didn't trust us to do it as the fellows, and used a I don't remember if it was 125 or 15 burr, but was too aggressive, pushed it past the lesion, and then it got stuck. So experience is definitely key beyond just the size of the burr.
True. So this is what I wanted to talk about today is, how do you manage this? So we
Get the
tried to
guideliner if the wire doesn't
we got a guideliner, we tried to pull.
Exactly.
We tried to pull, nothing happened. And then, again, we tried to pull harder, we got the guideliner even closer. And also, I guess the thing that we did not do in the beginning is that with the wire, we did not pull it back to the burr. We tried to keep the wire in the vessel itself. But I guess what we should have done, what happened here, is basically pulling the wire back to the burr so it can give us more support with the guideliner to get this burr outside from the circ, and eventually the burr came out. Maybe I missed the.
Did you try to put a second wire next to it?
No, we did not try to wire next to it. We pulled pretty hard, and eventually, this is maybe a long center, long floor save. So eventually, the burr comes out, and the next shot, it was pretty good. That
Did you have the guideliner already before you started?
No, we put the guideliner. We wanted to pull back.
He's
the
going to
burr.
show how he put the guideline on.
So the next shot.
That's how I want my one out.
Yeah, the next shot, the good thing, we did not have perf, we didn't have dissection, we didn't have perforation, so that was kind of a safe thing. Later on, I guess that stuck burr opened up the vessel more. We did some maybe endarterectomy with that guideliner. And eventually, we stented the left main and the bifurcation with the tap technique. I'm not gonna, I'll get you bored with all the steps of the stenting that we did, but eventually it was a safe, good thing. But so I just want to talk about this burr entrapments. I don't know if how many of you know this doll. It's called the Kokishi doll, and for some reason, getting the burr entrapped in the in a vessel is called the Kokishi phenomenon. So this doll is from North Japan. I don't know whether there's a doll that has a head bigger than its body, and I don't know how the name got there. Maybe it's the reverse. It's the burr and it gets stuck in that body. It's the disease, or it's they imagine already they need a guideliner to pull it out. But it's if you look at it, look it up. It's called the Kokishi phenomenon. It's very documented everywhere, and I didn't know why. But I had to look it up. So that's why they call it the Kokishi phenomenon, basically. So burr entrapment is reported to be not common, like 0.5 to 1%, but I guess it's underreported. I guess a lot of us have it, but I don't know how many of you reported the occurrence of it. So I guess it's underreported. It's probably common, but it's definitely more than 1%, but this is what we made it to the literature. So there's few steps we can do to prevent, proper sizing of the burr, trying to go with the lower size and, increase it, try to change the acceleration, like those stuff we can do to prevent the entrapment of the burr. But I guess the good thing on the rotafloppy wire that has like a thick end or like a spring in the tips that can help you when if you get entrapped, you want to pull it back. That when you pull it back, to give you more support if you have a guide liner too to get it. So use that wire. That spring in the end, it has that function that can help you to pull it back. And how to retrieve it, I guess those some pictures, of how you can cut the shaft and pull it back here. We recorded a quick video. I don't know if the sound's gonna work.
Can we get the volume up?
The volume up. I apologize.
A
The quality
rotablader,
wasn't that good. My producer.
or burr entrapment, also called Kokishi phenomenon. So basically here we have a 2-0 burr coming in. You can imagine that there's a sheath in Copilot going in 8 French GR guide, and you have the end of the burr here outside. Imagine it in the coronary artery, and we have a rotafloppy wire at the end. So basically, if you get entrapped and the tip of the rotablader is not moving anymore, what you can do is basically just lock this device, and then you need a cutter, a wire cutter. It's like not any regular scissors. You might get away with the regular scissors, but you need like a strong cutting machine. Usually you can get it from OR. And at this point, you should alert CD surgery if you have a burr treatment by now. Get like a wire cutter, and then you have to cut it by an angle here, like as close as you can to the shaft. You have to do it here with an angle. We'll try to cut it here and here, see how it works. Try with the angle over there. And then after cutting the shaft of the rotablader at an angle, so it can be easier to load the guide liner. The next step here, we have a 7 French guide liner. Since we have a 2-0 burr, it's not going to go on 6 because it's a 2-0, so the shaft even will be thick, not only the burr. So if you try to load a 6 French guide liner, it's not going to go on this one. So have a large one. And here we don't have much heparinized saline or lubricant, so it might be a little bit even harder, but it's not that difficult. So now it's going through the guide, and we'll do the rapid exchange part. So it's coming out of here. So you pin and advance. This is my okay. So again, you have to use your imagination a lot for this period. So once you have your guide liner up, coming out, I guess you can switch to the other side, coming out the tip of the guide, assuming this is the entrapment area. So 2 more things. So after you get the your guide liner up to the tip of the guide, now you're trying to pull back your burr. One more thing you can do so you can get more support with the pulling back is to pull back the wire, the floppy wire that you cut. So here you have the cover, then the shaft of the shaft, you have the cover, and then the burr, and then this is the end of the wire. If you pull it back, the rotafloppy wire from the end is thicker than the burr. So when you pull it back, it's going to also help you to pull back the wire more. Also, it's going to give you more support. So you pull back the wire, you pull back the also the burr, and you keep supporting your guide liner and the guide in order to be able to retrieve it and pull it back. Here, I guess not entrapped in real life that we're recording here, but when you pull it back, and then it should come out. So this is 7 French guide liner, and the burr is 2-0, so it's not going to go in it. And again, this is just to support your pulling back to the guide. So once you get it back to the guide liner, you can just use it all as a one unit, and then just retrieve it, do a shot, make sure there's no perforation or rupture. Thank you.
And again,
hello everyone.
My hands are not as fat in the video, just like not the best quality.
The other scenario is to bring the guide liner as far or close to the burr as
Yes.
possible.
Yes.
Actually, that's probably the better way to do it.
Yes. So why the burr get entrapment? Again, tortuous vessel, maybe not appropriate sizing, bad decelerations. When you push the burr pretty quick and you get like pretty quick deceleration, more than 5,000, that could be the reason. And very calcified vessel, that could be the reason. Other techniques, I get Some of the doctors here also some mentions like getting a wire up there and balloon it to dilate, proximal to the burr so it can get some more space. And after you push another wire, we're doing like a perforation technique. Get a ping pong, another guide, another wire, balloon proximal to it, and pull it out. Or if you can snare it, some people try to get a guide liner, snare it, and pull back. And I guess the most invasive I've seen is something called Benistar techniques. Is going with another guide, another wire, go subintimal, proximal, and then go back to the lumen distal, and then balloon and try to release the burr by ballooning and just release it proximal to the burr. So again, there's multiple techniques that's been described in the literature. I guess the safest one is just to pull it back. Some others, try to increase the acceleration of the RPMs and the rotablator to 200,000, try to push it in and then try to pull it back. It has like a decent risk of perforation or rupture complications. This is the suggested algorithm from the European Society of Cardiology on how to manage. So first, you need to alert a surgeon that we have a burr trap, because some cases might need surgery regardless what you do. It might end up needing surgery. Try to cut it, pull it out. If that doesn't work, maybe a balloon proximal to the burr. That doesn't work. Snare could be considered afterward. Maybe the Benistar technique could be also considered. And prevention, again, avoid like the very big jump of accelerations. Try to prep the lesion, or like use a smaller burr first, and IVUS to see what's going on, if the IVUS is going to go, especially if you have a stent. So this one happened, thank God, in a native vessel. If it happened in a previously stented vessel, if you pull back, you might deform the whole stent, and you have to snare it out, or like a stent on top of it again. Some report stated that it's safe to rotablate a freshly implanted stent. I don't know why you're going to rotablate a freshly implanted stent, how quick it's going to get calcified. I'm not sure about that, but you have to make sure you use an IVUS and you make sure inside the stent before you try to rotablate a stent, so you can know that you're not under a strut or something, and so you don't get like a disaster in the cath lab. And again, this is the quick issue though. Any questions?
No, I think in addition to the avoiding excessive forward force, it's also better to avoid excessive retraction force, because that can damage the vessel. So I think you have to have a low threshold to just deploy alternative techniques, like rather than trying to pull and get out of it, because that's going to lead to more problems.
Good. All right. Thank you.
Yeah. Good.
Having couple of say forward pressure, don't push it, let it just go, and let the rotation do the work, so that it doesn't get entrapped. So that has worked. The last body entrapment was 6 years ago.
What you're saying, you don't try to actively push. When you start the device, it will slowly move forward. Maybe you just kind of trigger it, and you just don't try to push it through the lesion.
So there's a lot of mechanics going on, but when you review the literature, was there any data towards the question that Dr. Prasad asked me? Is there any increased risk if you previously dilated or used high pressure dilatation, or if you can prevent it with IVUS based on the comments here? Did you learn anything about it?
I mean, like in order before you rota, like try to balloon more, then IVUS and then rotablate if the lesion doesn't expand, or?
Yeah, I mean, is there any data that, because what you did is use presumably some pressure, and then the question comes, we routinely, at the beginning when we're doing, that was a no-no. You're going into flaps and you can create this situation. Now in the picture, the lady, it looks very interesting, but I say that if you look in an ultrasound, you may have a bunch of flaps there intertwined, and that may be part of the reason. I don't know. Just to go back to what Dr. Chiruku was saying, maybe an ultrasound or getting a little bit of a feel whether you probably should not go in, because it's going to get dry.
I mean, some of it's how the patient's doing. If you're left with this and they're in excruciating chest pain, ST elevation, it's still very calcified.
You have to do it. But
you have to do it, but if you can maybe avoid it at that point, obviously,
Now, I guess we didn't believe that IVIS was going to go, and for the patient's hemodynamic, thank God we had an Impella in. I guess we planned it well that the patient low EF, and we had an Impella 2.5, that was 2.5 Impella. So it provided hemodynamic support. The patient didn't, crash, didn't develop any significant symptoms or significant hemodynamic instabilities.
But one of the things that Dr. Donovan pointed out, I mean, this is a scenario we don't want to be where you balloon and you need to dilate something that's not dilatable. I think that what do you call it?
Shockwave.
The lithotripsy,
Shockwave.
It's a nice alternative, not saying that you
True.
should
Actually,
not.
we've been using this a lot. Try to first make a room for the lithotripsy balloons by a rod ablator by small sizes, and then for this case, actually, after the 1.5, we shockwave afterward. But the issue with the shockwave balloon, they're bulky.
Yeah.
Pushing
it
them in
won't
a
be easy to
circ
get
system, the circ system, it was going to be pretty hard.
But in this, you had good expansion after 2.5 balloon.
No, but the shockwave wouldn't deliver. We couldn't deliver any equipment after that.
This
No,
is
it
spread
won't
way
be easy to put the shockwave in there.
it's that angled circ that always gives us trouble.
Yeah, it's a circus always.
It's a nightmare.
The issue also with the shockwave is that the shock portion is the second 2/3 of the balloon, so it's not just you put the tip of the balloon in the lesion. You actually have to get across
All
the
the way
lesion,
across.
Oh, yeah.
and then have it in the back end of the balloon. And I mean, I had quite difficulty getting it through in a lot of cases. So rota shock is what I guess most people are kind of.
I guess if there's debate, you can always try to put a shockwave balloon, and if it doesn't go through, you can go back to your other algorithm, but then
Right.
you might waste the balloon, the shockwave balloon.
Well, you could always use it after you rotablate. So.
That's the thing.
You can always
I
use
mean,
it afterwards, you're right.
once I've tried to dilate, I would try to get it down there if I couldn't, or whether it was just bringing a guideline, a balloon, and suck it down, and then whatever we have to do to get a shockwave down, although I haven't done shockwave through.
We haven't talked about
guidelines,
orbital
I'm sure we do.
atherectomy either,
Okay,
so
I have, but you-
potentially some less chance of the crown getting
You
stuck
can sustain it.
because you're treating both directions.
Yeah.
So, that often gets overlooked as an option.
All right. Thank
Thank
you.
you.
Thanks.
All right, everybody's right at 9 o'clock. Paul had to get to the airport. He's flying to Nashville in his jet, and then he's going to fly to New York in the morning. So he didn't want to stay up too late and then fall asleep. It's just him and his wife in the plane. So I want to thank everybody for coming out. I think this was really one of our most fun, safe events we've had. And again, thank you to our sponsors and all the participants and panelists. I think it was really a fun evening, so I hope you all enjoyed it and learned something new. So thank you.